A very good morning, ladies and gentlemen. On behalf of Sunway Medical Center, Sunway City, it is my pleasure to welcome all distinguished guests, speakers, moderators, participants, and as well as our online attendees to the sunmed Pediatric Symposium 2026, themed Pediatrics Without Borders, Integrating Subspecialties for Complex Pediatric Care. By transcending borders to get and bringing together diverse perspectives, expertise, and experiences, we aim to inspire meaningful conversations and foster partnerships that ultimately enhance the care we provide to the children and their families. Over the next 2 days, we look forward to insightful discussions, case-based learning, and opportunities to strengthen multidisciplinary partnerships as we navigate the complexities of modern pediatric practice together. My name is Farah, and I am honored to be your MC for these 2 remarkable days. Before our first session, we would like to start off with some housekeeping. Our free Wi-Fi is called Swan. There are 4 fire exits on this floor. Do take note of the locations in case of emergencies. There is one behind me, one right over there, one right down the foyer, and right near the toilets and the surround. As for the amenities, the toilet and the surround is just down the foyer to the right. To make the most out of our time together, we will begin this morning's program with our opening plenary discussion. Just to inform everyone, during our panel discussions, you will have a chance to ask questions. There will be a QR code for everyone to scan, including our online and physical participants, where you can input your questions for our speakers and moderators. Okay, we will begin shortly in 5 minutes. Thank you everyone for your patience. To introduce our distinguished speaker for our plenary talk, it is my pleasure to invite our moderator, Dr. Cheong Shu Ming, who is a consultant pediatrician and neonatologist at Sunway Medical Center, Sunway City, with specialist training in Malaysia and Japan. She has extensive experience in caring for premature and critically ill newborns. Beyond her clinical work, she also serves as the treasurer of the Perinatal Society of Malaysia. Please join me in welcoming Dr. Cheong to stage.
Thank you, Farah, for the kind introductions. It is a great pleasure for me to introduce our plenary speaker, Professor Dr. Chia Fook Cho. Professor Chia is no stranger to our neonatology fraternity. Over the past 4 decades, he has been a clinician, educator, researcher, and mentor who has inspired generations of pediatricians and neonatologists in Malaysia and beyond. He is currently the Professor of Pediatrics at Sir Geoffrey Chia Medical School, Sunway University, and he was formerly the Professor of Pediatrics and Neonatology at University Kebangsaan Malaysia. Professor Chia is a recognized neonatology internationally. He has authored more than 100 scientific publications, and his work has been cited nearly 3,000 times by researchers around the world, reflecting its significant impact on neonatal medicine and research worldwide. So ladies and gentlemen, please join me in giving a warm welcome to Professor Chia Fook Cho. Prof, the floor is yours.
Okay. Good morning, and thank you very much, Shuming, for that kind introduction. It's really, I do not have bifocal, so I have to take off and see. This is a sign of aging, you know. Well, it's really nice to see such a big turnout, and I'm really honored to be invited to give the plenary for this symposium. I was told that this is the 4th time this symposium is being organized, and I really congratulate the organizers for such compact and really relevant topics being covered in the symposium. And they are being delivered by the specialists who are all staff in this magnificent private medical center, supposed to be the best private medical center giving pediatric care in the Klang Valley or even in the country, yeah? So, I've been given the task to talk about this field, which I've been dedicating myself for the past more than 3 decades, the care of the preterm infant. So what are the advances in the care that I should be highlighting? You know, it's such a big topic, and initially I was told that I should be given only 30 minutes, but I said this is like, 30 minutes is not enough, you know, 45 minutes at least. And I still have to pick some of the areas which I thought should be highlighted, because I do not see much advances that we are taking or we are facing or we are going through in this country. And hopefully with this, I could stimulate, you know, the audience and people to forward the agenda of improving this area in the care of the preterm infant. Okay, so what is the impact of preterm birth in the world? If you look at the global rate of preterm births now, it's about 9.9%, well, about 10%. So about 1 in every 10 live births are preterm. So that's about 13.4 million babies born prematurely every year. And what's the impact? The impact is the preterm birth complications is actually one of the leading causes of death in children under 5 years old. In Malaysia, we have about 500,000 babies born every year. The rate currently being cited by the Ministry of Health Malaysia in 2023 in the guide published for it's a guideline for preterm birth, It's stated it's about 12.3%. So we're actually above the global average of preterm birth in this country. And prematurity is the second leading cause of under 5 mortality for our country. So it has got its impact in terms of its volume as well as in the way that we deliver our care to these vulnerable infants. This is just to show you what is the percentage of preterm births that are it's sort of what's the proportion of the severity of prematurity that is actually affecting, that we healthcare providers have to contend with. So if you look at it, most of it, about 75% are actually 32 weeks and above. And these are the group of babies who are rather large and who are rather mature, and they do not quite need so much intensive care support. So they should survive. But what we are not doing very well is those in the severity category of severe prematurity. So especially those who are less than 26 weeks. If you look at the composition of these preterm births, they constitute about 25% of babies born preterm, so less than 32 weeks, which we call very or extremely preterm. And we look at based on the data by the Malaysian National Neonatal Registry, the 28 to 32 weeks, we are quite good in salvaging, in caring, and in ensuring their survival. So about 80 to 90%. But we are not doing very well for those who are less than 26 weeks. Survival rate is only less than 50%. And that, I think, remains one of our challenges, including many hospitals, government hospitals may not even want to salvage 26 weeks and below. Yeah? So it leads to those centers which is highly specialized, has the backup, has the competency, in terms of the teams. That is a multidisciplinary team involved in carrying this preterm to be able to improve with the advances that we have at hand. So I want to show you this video. It kind of tells you what is it that is involved in taking care of a preterm baby. And this is a video by the March of Dimes. Those of you may have heard it. It's an organization that actually advances the agenda of saving lives, especially preterm babies.
On the second floor of this hospital is labor and delivery. Having a baby, normally a joyous event, is unfolding here as a tragedy. This is baby boy Westby, born at 3/4 pound. His heart is beating, but he's too small and his lungs too underdeveloped for survival. He is moved to intensive care, where the nurses will keep him as comfortable as possible while they wait for him to die. Baby boy Westby is one of 40,000 babies who die every year. Though we cannot save him, we can permit his memory to turn our thoughts to a question. What can we do to prevent these enormous tragedies? Back in the early 70s, the March of Dimes alerted the nation to the need for specialized care for babies who are born sick. The March of Dimes devised a plan and worked with the medical community to develop a coast-to-coast network of neonatal intensive care units, or NICUs as they came to be known. The objective, saving babies.
Newborn. Thank you. Pediatrician OR2 stat, abruption, 27 weaker, hot drop, fetal distress. Pediatrician OR1 stat.
Bonnie Holloman, 16 years old, 27 weeks pregnant. has an emergency C-section because of fetal distress. Yes, there's a baby in that blanket. Baby girl Holloman, 2 pounds. She's breathing on her own, which is a miracle for a baby this small. Because Bonnie's pregnancy was under a doctor's care and her preterm delivery was anticipated, she was given a hormone treatment which stimulates the baby's lung development while still in the womb. Without hormones, there wouldn't even be this feeble cry. Thanks to prenatal care, she has a fighting chance. That's why the March of Dimes aggressively promotes the value of doctor visits early in pregnancy. Baby girl Holloman is transported to the NICU. If she is to live, she must be watched closely by people and machines. Her body temperature, pulse rate, breathing rate, and blood oxygen content are monitored, and the care team battles complications that can end the life of a baby born too small and too soon. Too small and too soon, like baby boy Williams, 4.5 pounds, 34 weeks. Too underdeveloped to breathe on his own, medicine must breathe for him. In the NICU, he will be given surfactant, a vital substance missing from his immature lungs. This is one of many procedures pioneered by March of Dimes researchers, which can save a baby who would otherwise slip away. Medicine mends with technology, but it heals with compassion. The caress of these nurses, the concern we feel, can put life where death might be. Consider Jessica Elaine Austin, born at under 2 pounds. She's been struggling for more than 4 months and can't get well. But every day, twice a day, she gets new strength from the love in her father's voice and the warmth in her mother's smile. Was blind, but now I see. Baby girl Holloman. After 2 months in the NICU, she doubled her weight and went home at a spunky 3 pounds, 14 ounces. Prenatal care saved her life. Baby boy Williams, thanks to the miracle of surfactant, went home in 1 month and 7 days. He's got the whole world in his hand. Jessica and her parents won the battle. After 5 months and 27 days, she went home. We share in the triumph of saving these babies, but we must not rest. How can we, when so many more babies are in danger? He's got the whole world in his hands. In our hands, we have the power to help a child who needs us.
Okay, so a very poignant video, isn't it? And there are some terms in the video that actually I would further deliberate on in this talk. Yeah, for example, the drugs that the mother received to mature the lungs, which we say is antenatal corticosteroids, and some other elements in therapy that I will deliberate later. But I just want to highlight that, the team that's involved, you can see how many hands there are, trying to care for this tiny little infant in a nursery. And they constitute your obstetricians, neonatologists, all the various specialties that this hospital has, actually. Cardiology, neurology, radiology, pediatric surgeon, ophthalmology, audiology. Yeah, and of course, not forgetting the allied health. People who are really doing round-the-clock work, the nurses, the dietitians who have to come to advise on nutrition, the physiotherapists to come and position the limbs, and posturing, the respiratory therapies, taking care of the machines, the breathing machines that the baby is on, and of course the counseling support. You can hear me? Okay, that's better, isn't it? Just now was a bit soft, sorry. So yeah, the team, the multidisciplinary team of specialists who are taking care of this baby is just going to be very large, and we do need them because each of these personnel are going to contribute in a way that it will bring a positive outcome to these babies. So just go to one scenario, a case study. This is something that we often encounter. A couple who is 49, 46, very successful in their career, have been deferring having a kid. And this lady, is now gravid of 6, have no successful pregnancies, 7-year history of primary infertility, 5 failed autologous IVF cycles, and then conceived finally on the 6th cycle. Yeah, and antenatal course is now very good, both of them very happy. Yeah, unfortunately at 25 weeks, she suddenly develops this regularly painful uterine contractions, and then she noticed some leaking, and examination showed that this patient has actually gone into preterm labor and with also rupture of membranes. In fact, the cervix is already dilated and the labor is progressing quite rapidly. So this is what we encounter. Then the obstetricians who take care of this couple will call the neonatologist, and we discuss with the couple, what should we do with a 25-weeker, and we tell them about what's the possible outcomes, and then together we make a decision as to when to deliver and how to deliver. Yeah, but most of the time we want to give time for medicines to actually take its effect. Yeah, by giving them the maturing medicines that we're going to talk later on, and of course transfer to a care center where they can actually provide all this so-called specialized care to support this the treatment of this infant. So the first thing, the therapy that is very important that was mentioned already in the video is antenatal corticosteroids. And I think most of you would know this is really the standard of care in treating the preterm birth. So much so that the medicine given to the mother will cross over to the baby to mature the lungs. Yeah, and usually it's a single course given to any gestation. Threatened preterm birth about 34 weeks gestation, yeah? And it can also be effective even if given to those who are less than 25 weeks. And sometimes obstetricians say, the lungs are too immature and there's no point giving steroids and all that, but the evidence is that it does reduce mortality even up to 22 weeks, which is the cutoff for salvageability now. Now, even for 34 and 37 weeks, there are some benefits for antenatal corticosteroids because it reduces short-term respiratory mobility, but just bear in mind that it may increase the risk of neonatal hypoglycemia. Now, the optimal period for these antenatal corticosteroids to work is 24 hours before delivery, and the effects actually last for about a week. So if you need to do a repeat course, you usually will need to be given at 7 days after the first course, and it should be given just before 32 weeks, because after 32 weeks there are other complications that you may encounter with this therapy. Now, this therapy has been proven in many trials, and it is, like I say, a standard of care. And in fact, if obstetrician doesn't give antenatal corticosteroids to a lady with preterm labor, it is considered as below standard of care, because antenatal corticosteroids reduce remarkably RDS, neonatal mortality, intraventricular hemorrhage, as well as necrotizing enterocolitis. And how does it does its work? It stimulates the lung to produce surfactant, yeah? So making the baby ready to breathe air when it comes out prematurely. And it also stimulates the lung to go into a absorptive phase. You see, the lungs actually, when the baby in that gestation of 25 to 32 weeks is still developing, it needs its fluid, the amniotic fluid in the lungs, to enlarge the alveoli as it grows. You know, that's for maturation of the lung. But because the baby is coming out, obviously he needs to clear the water in the lungs, right? And so that he can breathe air. So antinatal corticosteroids can actually stimulate that, increasing the sodium channels as well as activating the pump to pump out the fluid from the alveoli so the baby are more ready to breathe. Now so that's antenatal corticosteroids primarily to mature the lungs so the baby can be transitioned to breathe air. Now the other thing that now obstetricians need to give is antenatal magnesium sulfate. And this is for preterm fetal neuroprotection. It is shown to reduce cerebral palsy at 2 years by 30% if you give to preterm birth before 32 weeks. How is it given? It's usually infused over up to 24 hours before the delivery. Now, the effects is amazing in the sense that even if you give it 4 hours before the preterm birth, it has been shown to have the protective effect on the brain. And the way it does it is it blocks the NMDA receptor, it downregulates the neuroinflammation, it also improves the cerebral hemodynamics as well as stabilizing the cellular membranes. So now I'll switch gear to talk about how we transition, the care and stabilize the babies who are delivered preterm, yeah? And this is termed as the golden hour, where we stabilize these preterm babies. And you're going to see now where we stabilize the babies now is going to be nearer and nearer to the mother, primarily because we want to start a delayed, or what we call deferred cord clamping. I'm going to talk about it later on, but this is just one of the scene that is actually what we are going to see more and more in this era in terms of resuscitating and stabilizing preterm babies with deferring cord clamping. But before that, one of the things that we must talk about is thermal care, because I find that it is one of the things that is usually not being given due consideration. We forget about it most of the time. Now, it's supposed to maintain the temperature of babies about 36.5 to 37.5. Okay, for infants below 32 weeks, traditionally, now we do not advise wiping them dry because it actually accelerates heat loss. So no wiping for any babies born less than 32 weeks below. We place them on occlusive wrapper under a radiant warmer so that you can actually stabilize the temperature. And the delivery room ambient temperature is advised with 23 degrees Celsius. So I'm not sure in this hospital what is your policy, but I've always been challenged with the management about temperature in the labor room as well as delivery suite, because infection control seems to think that a higher temperature invites more infection. I think that is something that we need to deliberate and consider. And of course, staff comfort, the obstetricians, during emergency section and all that, with all the gown and all that, they say, wow, the OT is so hot. Gosh, they can't concentrate and their sweat will start dripping onto the wound, and then they say the wound will get infected and all sorts of things. So I think this is very challenging, but the evidence is that if you increase the ambient temperature to about 23 degrees, babies do not get hypothermic, yeah? So I'm going to show you more evidence with that. Now, wet in bag resuscitation is when this were done for preterm babies less than 28 weeks. And this was a Ziploc era when I was training, So we put the very small preterm baby into a Ziploc bag, with all the amniotic fluid and all that. We do not wipe it. And they did a study and compare whether you place it in the bag or you do the normal thing. And they found that there is less hypothermia and the babies are much better off in terms of temperature if you do not wipe them, if you put them straight into the bag with all the amniotic fluid, yeah? And this effect is seen to be better if your room temperature, ambient room temperature is at 25 to 26 degrees. So this is how it looks like now when we manage babies preterm, see how they are wrapped with these plastic occlusive bags, yeah, and they are placed under the radiant warmer. And it's a very effective mechanism to maintain temperature. You know, the skin is so thin, it's hardly anything there, you know. It's not even thin, it's probably thinner than the tortilla wrap, or whatever wraps that you use, or the propia wraps and all that. So they're so thin, and the water and the heat just come out. And then before this, when I was practicing as an MO, I can see some of them shrivel to like a prune without proper occlusive wrapping. So it's very fast, I can tell you. That era is gone now, I hope. And there's one even very innovative people who do a shower cap for the head, you know, to reduce the water loss. Now, this study has shown that with this method, the temperature actually goes up very quickly. It's just within 3 to 5 minutes, your temperature stabilizes. So it's definitely one therapy that we need to implement and employ in our routine practice. This was before we know about how we should care into our thermal care for this group of babies. That almost all the babies who were born in that low gestation were hypothermic, yeah, and mortality is very high because of this hypothermia. In fact, hypothermia increases by 28% for every 1 degree Celsius decrease on admission temperature. And it also increased the late onset sepsis by 11%. So actually temperature is very important, but something that we tend to forget because we're so busy doing this and doing that, we forget about the baby's temperature. Now, this is another study that shows your ambient temperature in the labor room. If it's at 25 versus 22, I think most of our room temperature is set at 22. And if you go up to 25, your hypothermia rate actually comes down by almost half. Yeah, and in the OT as well. The smaller the babies, the more effective it will be if the ambient temperature is raised, yeah, even higher to 26 to 28 degrees. So it's pretty hot, you know, for ambient temperature. So for our comfort, maybe it's not so good, but definitely it helps to improve care and outcomes for babies preterm. Now, this is the other thing that I want to talk about. So this is delayed umbilical cord clamping, and this is becoming a standard of care already in this country. So no longer immediate clamping of the cord, yeah? So at delivery, you have to delay, for especially term babies, you are advised to delay for at least a minute, yeah? This WHO guideline. And this is for the overall health and development of the baby. So that's delayed cord clamping. But obviously in the preterm, you know, there's so much to do, and all the people are concerned whether delayed cord clamping can affect the care of this preterm. So there's another term now, some people call it deferring, not delaying it, but deferring umbilical cord clamping. So let's say it's at least 60 seconds recommended, who do not require immediate resuscitation. But what about those who need resuscitations? Somebody, Dr. Chiang Shuming is standing by for this baby who's going to be born 25 weeker for this couple, you know, and she needs to say, oh, I need, please do not tell the obstetrician, please do not clamp the cord. But, you know, how is she going to work there, you know? So she needs to bring the whole trolley over to the bedside. There are trolleys like that now. And she will start stabilizing the baby by giving CPAP and all that while the cord is still attached. Yeah, so this is called intact cord resuscitation. And you will resuscitate and you stabilize the baby, you know. And let's say if she really cannot, because maybe the cord is too short and all that, cannot get around it, so then you will ask the obstetrician to try to milk the cord, yeah, 4 times. That's called intact cord milking. But beware, anybody who is less than 28 weeks, probably you should not be doing intact cord milking because it has been shown to increase the risk of severe IVH. So this is a scenario, if you look at it, you know, how the people are all surrounding the mother, yeah? So it's probably the father here, and the nurse here, and there's the obstetrician here, and this is Dr. Cheong Shumin, the neonatologist, and this is her nurse assistant. So this is the whole team doing physiologically based cord clamping. The idea is, before we clamp the cord, we resuscitate the babies, we open up the lungs, we stabilize the respiration. So if you go back by physiology, you need to fill up the lungs with blood first. So if you clamp the cord, the blood is not going to go to the baby. So she is deprived of this residual amount of blood in the placenta. So if you delay clamping, the blood will go to the baby, and it will fill into her right atrium and right ventricle, go to the lungs, and then she starts oxygenating the baby. And that's the whole concept of what we call physiologically based cord clamping. Yeah? So if you look at it, so the aim is not clamping the cord before the lungs are aerated. Yeah? And delaying or deferring cord clamping is very powerful. It has been shown to reduce the need of blood transfusion, stabilizes the circulation and the blood pressure of the baby. It does reduce IVH and also decrease NEC. Yeah? So avoiding immediate cord clamping, which we used to practice, yeah, will reduce in-hospital before discharge mortality. It reduces the combined outcome of death and disability at 2 years. And the longer you defer the cord clamping, the more beneficial it is. And the longer, like defer up to more than 2 minutes, is associated with even the lowest risk of mortality. Yeah? And you can imagine as well, this placenta blood flow is actually at a normal body temperature. So it also helps to improve and stabilize the baby's temperature as well. Okay, we move on to early respiratory support, where we want to open up the lungs. We want to encourage the baby's spontaneous breathing. So the technique is we use CPAP. We offer gases continuously flowing to achieve a pressure of 6 centimeter water. And preferably, we should be using humidified heated gas, yeah, during resuscitation and stabilization of this baby, okay? Because it has been shown to be associated with less hypothermia on admission and keep the baby warm. So this is how you do it. You say you can. If you are familiar with this, is what we usually use, what we call a T-piece resuscitator to give CPAP. So this is how we deliver CPAP with a face mask, and this is connected to a humidifier to actually resuscitate the baby. So I hope people are introducing this, but I think many centers are still not humidifying the gases during resuscitation stabilization of the preterm baby at birth. And you even have limbs like this that can actually humidify the resuscitation gases delivered. Yeah? Now, we have done a study, but this is a lamb model that I was involved in with the Americans in the study. When we use cold air, 21%, this is how it becomes. You know, if you look at the control cilia, this is cilia that we show on electron microscopy of the lungs of the lambs that we did the study on. This is control. See how nice tuft of cilia they are. But if you use cold gas, they become flattened like this, you know. So whatever carpet grass you have, very nice one, becomes like stepped upon by somebody. And this is because it was done by delivery of cold gases. Yeah? And if you use 100% oxygen, which you shouldn't be using, with the cold gas, it's even worse. You know, it's like so many almost flat patches of cilia. So they're not happy. So that is already the so-called base or fundamental for us to so-called extrapolate that using humidified gas in resuscitation is probably a better thing to do than using cold gas delivery. Now next we go to oxygen. We all know we shouldn't be using 100% oxygen in resuscitating because it's harmful. Yeah? And do you know that if you do a so-called transcutaneous or a pulse oximetry of a fetus, you know, the oxygen saturation is only 42.8%. So can you imagine they're actually blue? So we always say Virginia Apgar needs to revise her Apgar score already because no babies be born pink at birth, you know, so you never get 2 points for color. So that, I think, is something to sort of make aware that babies actually in utero, they are quite blue, yeah? And that's why they have fetal hemoglobin for the oxygenation. So naturally, in the first few minutes, you do not expect their saturation to be 100%. In fact, it's up to about 5 minutes only. It's an average saturation of babies about 85%. So that's important to know because that helps you to avoid giving too much oxygen in the first few minutes just to target 100% oxygen, which you shouldn't be needing to, because it's been shown that up to 5 minutes, oxygen saturation of a baby is only about 85 to 90%, yeah? So what you need, how do you know how much saturation is this baby having? You definitely need a pulse oximeter, and you also definitely need a blender, yeah? So that you do not give 100% oxygen, and you know how you titrate giving the oxygen to the baby based on the oxygen saturation as shown on the pulse oximeter. Now, this is NRP 9th edition. Those of you who need to do NRP, we should know this is the latest edition. And what's the oxygen concentration advised to be delivered during stabilization and resuscitation of a preterm baby at birth? So for late preterm, 35 to 36 weeks, you are advised to use just air, 21%. Do you know some modern hospitals don't even have wall air? Yeah, so it's just wall oxygen. 100%. And there were a time where the baby was born in an A&E in a hospital that I won't mention the name, and there's just no air because all oxygen is walled is 100%. So what do? You know, so the baby was given 100% oxygen, and you can see instantly the baby turns red like a lobster, practically like a lobster red, you know. So there was so hyperoxic, yeah, and you really need, now for standard of care advances, you do need air. Do not save money. The building facility will say, oh, it's very expensive to pipe in air and all sorts of things, but for a neonatal setting, you must insist you have to have blending of air and oxygen because, for example, in the 35, 36 weeks, it's air only during gestation, yeah? And for moderate preterm, 32 to 34 weeks, 21 to 30%. And extreme preterm less than 32 weeks, you are advised to use more than 30%. So the jury is out as to how much, because there's still not enough data as to what is the best oxygen to start off with, yeah, to resuscitate babies. But we know that the very preterm needs a bit more, yeah, and to achieve the saturation target of at 5 minutes reaching 80 to 85, 10 minutes is 85 to 95. And the pressure you should use, if in case you need to give positive pressure, is 20 to 25 cm water for babies below 32 weeks. Now, this is one of the studies that I have been involved in, and we noticed that we were comparing starting oxygen at 30% versus 60% to resuscitate babies. These preterm babies less than 28 weeks, yeah? And we found that if we start using it higher at 0.6 or 60%, we find there's less need for chest compression and the need of adrenaline to resuscitate them. So that's it, kind of tell you that the very preterm, the extremely preterm babies may need higher oxygen during the initial phase of stabilization to achieve the saturations. Okay, and this is another systematic review to show that if you use almost 90% to start off with to stabilize them, you actually get a better outcome, yeah? And with a better survival as well as cognitive outcome at 2 years. So we move on now to surfactant, this is a drug that's really a game changer, I would say, yeah? And no nursery should have no surfactant because it is shown to improve survival, reduces oxygen exposure, minimizes ventilator requirements as well as pneumothorax, yeah? So what we now advise is how it should be given, yeah? So for babies who are less than 24 weeks, yeah? It is advised that we intubate and give the surfactant because these babies are almost always going to be continually mechanically ventilated, just because they do not have the appropriate breathing effort, yeah? But if it's 24 to 28 weeks, when they are larger, it's now advised to give the surfactant using the LISA or the MIS method, okay? And those babies who are more than 28 weeks or 1 kilogram, we should even consider something less invasive that doesn't need the laryngoscope, which is the LMA size 1 or supraglottic airway. There is currently a trial looking at whether you intubate babies and then stabilize them by ventilating them with high frequency, by opening up the lungs and then give surfactant versus this less invasive method of giving surfactant. So we will await the results for this trial. So what is the problem with giving surfactant the way that we are giving now? Or previously, when we shove in a rather big endotracheal tube and then we put the surfactant in, instill surfactant, and then we start bagging, right? We need to bag. So that is where it's wrong. The bagging itself tends to overinflate the lungs and can actually rupture those alveoli, especially with surfactant. Number 2 is, a lot of times after you put in endotracheal tube, after you give surfactant, there is a tendency that you do not want to remove the tube. You leave it in, you continue mechanically ventilating a baby. So that is what the problem is, even though it's called insure, intubate, surfactant give, and extubate. But a lot of times it may not happen, So that's why studies have shown that by giving the less invasive method, when the baby is still breathing on CPAP, and you give the surfactant by LISA method, it may actually give you better outcomes. So it's actually the currently accepted best method, like I said, it avoids all these, the problems that we encounter with intubating babies. It does reduce BPD among survivors, and also it reduces the respiratory disease at 2-year follow-up, So I see Dr. Nozila in the midst, I think. So we will have less BPD and respiratory disease for these patients, for her to see at 2-year follow-up. So this is how we do it. If you see this catheter, this is the LISA catheter that we use. It's a very tiny catheter, and while the baby is on CPAP breathing, you will laryngoscope baby. You can use a video if you want to, because it's shown to help better because I think we are losing our skill to intubate babies and laryngoscope babies now. So with the video laryngoscope, you can actually see the vocal cord, and you just put that little tiny catheter while the baby is breathing with CPAP and instill the surfactant through the vocal cord into the lungs. And this is one study that my trainee, and now she's a specialist, did. He presented at perinatal and showed that with this method, there's a bit of reflux, definitely, especially if there's a large volume of surfactant given. So a way reflux, as you can see here, coming out, but it doesn't affect the oxygenation, doesn't affect the duration of mechanical ventilation or even respiratory support. Now this is what we call the supraglottic airway, So this one, you do not need to laryngoscope the baby, you do not need to, you just place the airway into the baby just above the vocal cord, and then you can give surfactant and also manage by stabilizing the baby. This is called SALSA, and we are in the midst of creating a curriculum to train healthcare providers to use this airway management. The only problem with this airway is that the smaller size is only about 1 or 0.5, whatever you call it. And that usually only fits in babies who are at least 1.5 kilos. So until we get a better airway, a smaller one for the tiny ones, I think this is one of the major limitations, So babies also need caffeine, coffee. I haven't got my coffee yet, actually. And caffeine is an established treatment for apnea of prematurity. It's used before extubation. It reduces respiratory support time, reduces BPD, improves neurodevelopmental outcome. It's also good for the brain. So coffee is also good for the brain. And early caffeine therapy, if you start caffeine early for babies, previously people argue, why do you give caffeine to these babies when they're still being ventilated? Only give them after you pull the tube up and when they're breathing spontaneously. But the point is, you want to be ready. You want them to start breathing faster. So if the The premise is if you give them early, they can have a better respiratory drive. You may be able to extubate them earlier, yeah? And it's been shown now that if you start them early within the first 2 days, it's got reduced BPD, reduced IVH, reduced ROP, reduced PDA, reduced late onset sepsis. A very powerful therapy. Simple, coffee, loading of 20 milligram per kilogram, and continued with maintenance, yeah? Well, having said all this, some babies, especially the very preterm, less than 26 weeks, they do not have a good respiratory effort. So inevitably, they need to be supported by mechanical ventilation. And the way to do it is, you need to use an open lung concept, and you need to look at ventilators that can provide volume-targeted ventilation, yeah? Or use a gentle mode of ventilation like high frequency. And the volume-targeted ventilation is, how does it work? It sets a volume that is set for the machine to deliver this gas to the baby so that it would not over-distend or over-inflate the lungs. And using this strategy, you can extubate earlier, and it's less air leak and also less BPD. Now, I think the final part is on nutrition. It's very important. Once the babies are stabilized and being managed in the NICU, some of the things involved in terms of delivery of nutrition needs to be discussed here. So one of the things that's new is called what we call immediate kangaroo mother care. Immediate kangaroo mother care is now proposed for especially low and middle income countries, where you initiate skin-to-skin contact, just like a kangaroo in the pouch of the mother. It is now recommended you do it immediately after birth, as long as the babies are not in shock or needing ventilatory support. And this way, you actually decrease hypothermia and early sepsis mortality. And exclusive human milk and donor milk is advised for feeding of the very preterm baby, and also consider the use of probiotics, which is shown to reduce severe NEC as well as late onset sepsis, yeah? So kangaroo mother care in 2016 has already been shown to reduce lower mortality, about 40%, fewer infections, higher rates of exclusive breastfeeding, and better weight gain. And this were primarily on term mature babies, yeah? So recently, the publication in New England Journal of Medicine is on immediate kangaroo care, mother care, and it does improve the survival of infants with low birth weight. You can see these babies are on CPAP or on respiratory support still, and they are on the mother's breast for kangaroo mother care. So the results are very stark. You actually reduce death, you reduce hypothermia, and also reduce suspected sepsis. Now, going to human milk, one of the most important nature's given nutrition to babies, yeah? And it's been shown that using human milk actually reduces NEC so significantly that overall the cost to the hospital is remarkably slashed. So it's one of the things that all hospitals should consider, enforcing protocols and strategies to really increase the use of human milk. So if you look at the WHO guideline, says, use of PES, even promote use of human milk for preterm low birth weight babies with priority using the baby's mother's own milk. And if it's not possible because the mother may be sick and do not have enough milk, use pasteurized donor human milk. It's the second option. So where do we get the donor human milk? Well, there are many people who are willing to donate, but the issue is how do you make sure that this human milk is actually safe for consumption, because diseases can be transmitted through that way, right? So there must be a way to have a safe so-called environment to process these, and Singapore has started what we call a community milk bank, where mothers who got excess milk can actually donate for them so that this can be processed safely for the consumption of babies who need it in the NICU, yeah? But in order for them to do this, you do need to have a lot of lactation support and education in hospital first, this lactation support is important to support people to continue breastfeed, yeah? And by doing that only, we can actually ensure a continuous supply of breast milk. But one of the problems in a country with the donor milk is milk kinship. So according to the Muslim religion, if milk kinship is, when a baby has been given 5 times full feeds from a mother, that becomes a relation, so it's called milk kinship. So I think the government and the Ministry of Health is trying to look into this way, in a religious way of how to troubleshoot and how to have the use of donor milk in the context of this country, major religion being Islam, and how this can be actually used in a proper way. So one of the ways is, the other option is, of course, use commercial. And how do this commercial human milk make their milk Sharia compliant? They actually have very strict protocol in ensuring that each of the milk being constituted and sold do not have, the feeding to this baby will not be more than 5 times from a donor. So a very complicated algorithm, but they actually have been endorsed by many of these Middle Eastern countries to be able to sell, but they're pretty expensive, So what is in the future? This is it. Maybe we're all looking for future lacto engineering, You can actually grow human milk, maybe just in about 3 years away, So practically growing it in the lab, to produce artificial human milk, So finally, talk about probiotics, So I think most of you probably are also taking probiotics, but just be careful that in neonatal care, probiotics means specific strains of live beneficial bacteria, not just any of the yogurt strain of probiotic that you are taking. So, and this includes bifidobacterium or lactobacillus. How is it beneficial? It's been shown to prevent NC, reduce late onset sepsis, as well as improve feeding tolerance. Now, so what happened was the FDA or the Americans are a bit cautious because they have encountered problems with overuse and abuse of commercial probiotics, because everybody thinks it's beneficial and healthy bacteria. So a lot of people start using over-the-counter probiotics, and there have been cases of infections, severe infections of preterm babies from sepsis when this so-called beneficial bacteria overwhelm the system of the preterm baby and cause infections. So that's why FDA is very careful now in terms of the use of probiotics in nursery. But in the European context, it's been conditionally recommended for less than 32 weeks and less than 1,500 to reduce NEC and overall mortality. Now the conditional approval is you must look at the safety criteria. It must be a pharmaceutical grade probiotic, and strain-specific matters. So they only recommend specific strains if you want to use probiotics in the nursery. And these are the strains recommended and the dosing, Lactobacillus GG, Bifidobacterium infantis, and the multi-strain combination are these. Now these are all done by rigorous trials to come up with the dose and the effects. So only these strains are recommended currently. So why no probiotics yet for our country? Because are we ready? We need to be ready. We need to look at whether we have pharmaceutical grade quality product. Currently, I don't think there is. Most of them are food grade, Food grade. So we don't have that. And then we have to ensure the strict strain that is being recommended. And because this is not a pharmaceutical thing, it's a dietary supplement, so it's not regulated by the NPRA, this National Pharmaceutical Registry Agency. So you may need your pharmacy or your lab to actually support you if you want to use this probiotic in the context of an intensive care setting, Like for example, if Dr. Gan wants to use in Paeds ICU pharmacy, you have to ensure that the lab is able to detect the blood culture, in case there is a case of sepsis, that it's not due to the probiotic, because it has been shown that you can actually get probiotic sepsis in the very preterm, because it can actually overwhelm the immune system sometimes, and your lab should be able to identify whether that strain it appears in the lab, the blood culture. Yeah, and if a baby is not being fed with breast milk, you shouldn't be using the probiotic. Yeah, and especially if the baby is not feeding, you should also avoid it. And avoid contamination. So if your nurse is handling this probiotic, you have to make sure that they go by the sterile, aseptic method, because this is actually a live bacteria. So if you're not careful, this probiotic will spread to surface supposed to be sterile and can cause contamination. So these are all the considerations, because I think a lot of people ask, hey, we hear probiotic is good, why are we not using it? And this is the reason, yeah? Okay, so this is my final slide. So in summary, I think this theme here is how important multidisciplinary care is. I think you have seen what the big team we need to actually stabilize and care for this very vulnerable group of preterm infants. You have, starting from the planning stage, the obstetric and neonatologists, midwife, nurses, all need to plan the delivery of this preterm and give them a proper setting, institute the antenatal therapy like corticosteroids and magnesium sulfate, and then we come in to stabilize, maybe we could consider increasing our ambient room temperature, make sure we have the plastic wrap, the incubators, the blenders, the CPAP, the humidification, the surfactant, the caffeine, and then maybe start considering doing the physiological-based cord clamping, yeah? And have the proper equipment for it. And in NICU, we should consider, Dr. Cheong, maybe start immediate kangaroo care. Teach our nurses and support the mothers to do immediate kangaroo care and make sure that there's a lot of lactation support to get our human milk, and consider maybe donor milk sharing in the way that's allowed by religion for the Muslims, yeah? And consider probiotics in the context I've discussed just now. And post-discharge, of course, don't forget, we have a lot of people that need to support us and these infants in their journey. Yeah, it doesn't stop just in the NICU, obviously. It's also post-discharge. You need your developmental pediatrician, you need ophthalmologist to check their eyes, their hearing, physiotherapy, speech language, occupational therapy, and of course the diet. So this is important for their rehabilitation, ensuring that they have got proper hearing, vision, posture, growth, and to optimize their learning. So that is all I have for you, and thank you very much for your attention.
Thank you very much, Prof. Chia, for the outstanding and insightful plenary lecture. As we are running on a tight schedule, we regret that there will not be any Q&A session following the plenary lecture, but I am sure Professor Chia will be very happy to continue the discussions during the tea break. So please take this opportunity to approach him with your questions if you have any. Okay, once again, please join me in thanking Professor Chia in the usual manner. Thank you, Prof.
Thank you very much, Dr. Cheong and Prof. Chia, for the lovely session. Before we continue, we would like to kindly remind everyone to put your phone on silent. This is to minimize interruption to the speakers and to your fellow participants. For our next symposium, the theme will be Navigating Complex Cardiopulmonary Care in Children. To introduce our next session and welcome our distinguished speakers, it is my pleasure to invite our next moderator, Dr. Ang Hak Lee, a consultant pediatrician and pediatric cardiologist at Sunway Medical Center. He obtained his Doctor of Medicine from University Kebangsaan Malaysia, followed by a Master of Pediatrics from the University of Malaya by completing his fellowship in pediatric cardiology. Prior to Sunway Medical Center, he served as a senior lecturer in the Department of Pediatrics of University Malaya, where he contributed significantly to clinical care, teaching, and specialist training. Without further ado, let us welcome Dr. Ang Hak Lee.
Thank you for the kind introduction. So welcome to the symposium. And we're going to start the first symposium, Navigating Complex Cardiopulmonary Cases in Pediatrics. So we have our first speaker here, Professor Gan Jing Singh. I think most of you know him lah. Huh? Okay. He graduated from Manipal Academy of Higher Education, India in 1998, obtained his Master of Pediatrics in University Malaya, and he joined University Malaya in 2007, because he's my colleague. Yeah. So he continued with her subspecialty training in Malaysia and also spent 2 years in Birmingham Children's Hospital, United Kingdom. And now he's a professor covering both University Malaya and also Sunmed Medical Center. So to navigating the complex cases, we're going to start with the cases first. So he's going to talk to us about when the family said not yet, a second opinion on tracheostomy. So let us welcome Professor Gan to give his talk. Thank you.
Thank you, Dr. Ang, for the kind introduction. So I'm going to start with this first symposium, and I'm going to give you the introduction of this complex case. So this is baby K, and referred to us at 3 months old, and it's a child that have 6 failed extubation, and family requests for a second opinion. So the tracheostomy was proposed as a safety strategy, and because I failed 6 times. And in fact, you know that pediatric is the one that keep tracheostomy quite late in adult. If anyone that ventilated more than a week and not able to be extubated, you think of tracheostomy. So we are going to receive this child and review and provide our opinion. So the question here is airway going to be the answer, and it is going to make the child safe, and the care, is it the best? So a little bit of background of this premature baby. It is 35-week gestation age and have RDS that require a dose of surfactant, and eventually have neonatal sepsis, ventilated, and discharged home. Unfortunately, about a month old, the baby collapsed and require mouth-to-mouth resuscitation by mom. And the baby survived, reaching hospital, intubated, and detected to have viruses that include rhinovirus and enterovirus, and they presume it's because of viral infection and required to be intubated, resuscitated. And in a hospital, the child was attempted extubation, but failed 6 times. And all these 6 times are not the easy one. And each time that extubated, the child will have desaturation and near life-threatening kind of situation. And there are many incidents that the saturation dropped to the level and have a bradycardia. So this is the child that we're going to receive, and we are just going through the story of the child, and including the investigation that was performed. It was seen by cardiologists, seen by intensivists, and they are seen by respiratory physician, and bronchoscopy also was done together with CT scan that review left side airway issue with narrowing, and they're just not able to make the child better by extubating the child. So this is the X-ray of the child. Yeah. From the left, you go all the way to the right, and then come down. So you can see that the lung is quite kind of a collapse, consolidations, and multiple pneumonia changes. And left lung is the one collapsed more than the right side, but both also been affected quite badly. And what is striking is the heart is huge, right? And this child has congenital heart defect, atrial septal defect, together with patent ductal arteriosus. So this is the case that will come to us. So before transfer, we have know the child is ventilated on a moderate setting. This is the pressure 22/8, rate of 30. Fortunately, the oxygen requirement is not that high. And ventilation we talk about, the heart part also we have talked about. The airway. So this airway is the one, sometimes you hear air entry, sometimes you do hear entry, especially on the left side. And infections, Acinetobacter bacteria are isolated. And the child, as a background, nutrition also is not ideal. It's a premature, together with anemia, recurrent infection also kind of make us think whether there's some immunodeficiency on top of this borderline premature. So challenge is whether we're going to identify anything which is reversible, and are we going to make the child better? So this discussion here will be like, is tracheostomy going to be the answer? If you do a tracheostomy, yeah, maybe going to be safer, doesn't need to be facing the desaturation, hypoxia, and causing injury to the brain. Should we just give another attempt? Am I or the team here in Sunway going to do better as compared to the other tertiary hospital that also equally have the subspecialty group that dealing with this? Or are we going to just sit down and discuss and see the whole dynamic? Are we able to make it come up with a different plan? So tracheostomy definitely is still a valid option, but we're going to take this child in and discuss. So this is the team that we have in ICU. It's not the latest one, but I think it was taken, probably was 8 months ago. So this is our team. We have nurses, that is our backbone, and we have our manager sitting here, and we have Han, that is a play therapist. We have physiotherapists, we have dietitian, pharmacy, that in-house. And we have this full team of people that working together. So to me, it's because of this group of people around, I find our role to be here to collaborate with everyone to deal with complex cases. Yeah. So everyone is so happy. Well, that's the best picture that we have. So what we know so far, the echocardiogram show this is left to right shunt still, the function is still good, and there's a shunt at the atrial level and also at the patent ductus, and CT scan and bronchoscopy show a distal left main and proximal airway narrowing. And Dr. Nozila later on going to show you all these in detail. Yeah, and what we have seen is recurrent left lung collapse most of the time, and a lot of secretion, infections a problem. So we have all these people involved. Yeah, the cardiologist definitely coming, respiratory physician will be here. We're going to talk about radiology, and of course ICU will be the patient we're going to admit to. ID, because infection have to clear, dietitian, poor nutrition is issue, and a lot of medication, and we need physiotherapy to be in. So as a pediatric intensivist, often that we are just, the one execute the order once we have a plan. So my job is to stabilize and support all the organs. And in this case, in particular, we have to make sense of what actually have caused the child to be deteriorated. Yeah, he collapsed at home and then came alive with the support, how to make the child better. So we bring people together and we prioritize what is the main thing to be carried out, and be very mindful about time is also important. And at the same time, we have to calm down the anxious parents. Yeah, I'm sure you can imagine that parents that have been informed there are 6 failed extubation, how anxious they will be when they come to us. Yeah, so one of our job is to constantly talk to parents, update them. So this is a picture I asked Gemini to create. I tried a few AI, doesn't give you a nice picture, but this is probably the best. Gemini, I compared ChatGPT and Cloud. Yeah, so we have ASD PDA here, causing lung a little bit over circulation, and the blood vessel is all enlarged, causing this airway a bit compressed. Yeah, and because of that, left lung collapsed down. And clinically, the baby has increased work of breathing and is ventally dependent. So this speaks all the problem that the child has. Yeah. So we think the defect of the heart is not it's not an absolute kind of size, this size, so therefore you must do this and that. But it's more like this is a dynamic situation, and therefore we think, perhaps optimize the heart failure control. It may make the child better, and also because if you treat the infection, secretion will less, then lung collapse will become less the issue. And because of all these issues that the child has, the infection on the lung, and on top of that, the child also has gut infection. Yeah, just barely, 3 days, the child actually have bloody stool, and that isolated, some organism, and that make the child even worse. We cannot feed the child and had to go on TPN. Yeah. So ID had to come in to help us in this situation, and all these will narrow down our, the chances of making the child better. Yeah? So our error of the margin of error is very small. We cannot afford to make any further, error to make the child worse. So option: wait or proceed to do something. So if you wait, so when you wait, meaning wait not to do any surgery, so is to treat the infection, make the child better, fatten the child a little bit, and reason to proceed is because I failed 6 times, are we going to try the same thing? And surgically, we have surgeon, we have Dr. Ahmad, we have Lee Wing Seng, even outright now, both are top surgeons in the country that are able to do the surgery. Yeah, and of course, airway-wise, we have ENT surgeon, we have respiratory physician, Dr. Nozila, and Dr. Zihan, and we have able to support them. So this is, at the end, the MDT consensus. We want to treat the infection aggressively, optimize the child condition, both lung and also nutrition, and we are going to do the surgery to correct the heart. So the outcome is surgery done, yeah, there's no more shunt, and we're still thinking that eventually if the child not better, we might still need to consider tracheostomy, yeah. Because once you close, it's not like a blood vessel going to become smaller immediately. You got to take some times. But we managed to extubate the child at post-op day 4 to the non-invasive ventilation. Yeah, and here is a successful case, and the child doesn't need to go back with any ventilator support. is going back home with air, not requiring even oxygen. So this case show, it's not to say one thing lead to all the problem, but it's the whole package of the things that we need to deal with to make the child better. So this is the post-op picture. The one on the top left is before the surgery, where the child was intubated. Heart is big, and then after surgery, when the child is extubated, you can see the heart becomes smaller. Yeah. So this is how it goes. And after the surgery and optimization, this is eventually the condition of the heart. So all these things are done, I think that our job is not over. More to that is, after extubation, a lot of physiotherapies need to be carried out to ensure airway clearance, optimization of the lung. So our physiotherapy come in. We also need to wean off the sedation very slowly, because sedation, if you wean too fast, you're going to cause withdrawal issue, and that going to cause complication as well. Nutrition is also a huge area. When a patient cannot be fed enterally, need to go to parenteral nutrition. We have to gradually introduce the enteral feed again to optimize the child's nutrition and improve the weight. And feeding with our dietitian help, yeah, that will be able to do it and make the child better. The final outcome is the child was weaned off to the room air and on full enteral feed, and even initially is all on the tube feeding, and baby children being so resilient, actually you were able to tolerate oral feeding after a lot of this oral stimulations with the help of our speech therapists. So the child able to suck orally, and the NG tube can be weaned off completely. So you have nice weight gain, and the developmental milestone of the child was actually achieved normal milestone. And the baby eventually discharged home after almost about 2 months. So the second opinion that we are asked to do, actually, really, is not completely different things. To us, this is actually a continuity of care of the child. And one cannot say because the other hospital have come out with the plan of doing tracheostomy, that is the plan, is a wrong plan. But it's more like continuity, the condition evolved. And we have to respect the decision that made by the other hospital at the time. And because mom, kind of disagree, and we have to look into the matter and then really discuss and sit down and find out whether any, factor that is still can be optimized, which is still reversible. Yeah. And it shouldn't blame on the other hospital that not doing their best. Yeah. And we have to make parents understand any second opinion is they're entitled, their right to do so. And every hospital have their, team that are able to work together to help them. And we should also prioritize the family first, together with the child, and help them with the complex situation. So, the second opinion, a lot of times, it depends on your local team, how well it can come together. Yeah, and it's not about stabilization alone, but we also need to listen to parents, check the patients, put all the investigation together, yeah, and ask the right question. What is the problem? So in this child is because of failed extubation, and we find out it was the dynamic situation due to the heart failure that has not been optimized enough, And infection is also another factor, together with nutrition, prematurity. Yeah, and with the right team that can come together, sit down and discuss, and the plan being carried out and carefully we monitor. Yeah. So the benefit of the child, is it come to a center that we have all the team that we have been working together, and we are able to communicate and help the baby to overcome all the clinical problems. And the risk of problem when they have this huge MDT is sometimes different people will have different opinion. If you are not able to settle, then you end up with argument, yeah? And it can work either way. So the lesson we can learn from this case is, every situation that we encounter is not just the diagnosis, clinical diagnosis, but it's more of the unique situation. You can name them as a phenotype, yeah? And not every patient are the same. We have to take their anatomy, physiology together, put them all together in this unique child, and come up with a unique plan and see how we can help them. And for this particular child, when they fail, we always go to ask, is there anything that we can do differently to make the reversible cause, to tackle and make it a successful situation. So with that, I thank you.
So thank you very much, Professor Gan. He's very kind and illustrated the very complex case very well. Okay. So next, it will be our second speaker for the first symposium, Dr. Nozila binti Muhammad Zainuddin. He graduated from University Kebangsaan Malaysia and obtained her Master of Medicine in Pediatrics from University Kebangsaan Malaysia as well. And she is the first pediatric respiratory physician for Kementerian Kesihatan Malaysia. And she is the one who established the Paeds Respiratory Service in Institute Pediatrics many years ago. So she's going to give us a talk on heart versus lung, deciphering the true causes. Thank you.
Thank you, Dr. Ang, for that. Now, I'm speaking after two professors. And I'm going to make it simple because although the topic is about navigating a complex case, if you put 2 and 2 together, you find that it's not too complex, all right? And historically, over the years, when I was in Institute Pediatrics working with the Institute Jantung Negara, with receiving referrals and so on, we always have, the heart and lung have a very, I don't say it's a very stormy relationship. At times it can be stormy because, when you get a referral, most of the time they say, hey, it's not the heart problem, it's the lung, so work it out, please. In some way, I guess because I'm quite senior, the relationship between the cardiologists, the heart and the lung is a bit more amicable, where we can sort of have an open discussion about things. At the end of the day, you want to have a good outcome for the child. Now, I'm going to talk, it has been discussed. I mean, I can make it short and say this is the verdict, but just to go through that exercise of this presentation, we're going to talk about the reasons of failed extubation, about the shunt, and the impact to the heart and the lung. Not just heart and the lung, it does affect the brain, it affects the gut, which is not in our discussion, and how do we investigate, and of course, the verdict. Now, we all know about this story already. At the end of the day, the key point is this child had prolonged ventilation, failed extubation 6 times, and The thing that is tearing to you is a large ASD and a moderate PDA. This baby is on 4 anti-failure drugs. That tells you something already. And remember, this is a 35 weeks child baby who has been ventilated. And of course, I saw in the note, pulmonary hypertension, likely to be lung pathology. That's why we need to send and settle this problem. And of course, Prof. Gan has illustrated all the findings of this child. Whoever lived in this era would know this character. Only people who live in my era. The younger generation, the Y, the Z, would probably not know this character. But he's my favorite character. All right, and so we're going onto this investigation about, hey, who is at fault? Is it the heart or is it the lung that's causing this problem? You know who is this? The young ones. My favorite character, Mr. Sherlock Holmes. And what does he say to Mr. Watson? Dear Dr. Watson, it is elementary. So we go back to the elementary. Although I did read in a publication that say, actually, Sherlock Holmes did not say in any of the novel that he said to Dr. Watson, it is elementary, Dr. Watson. That's what I read. So a few causes, and I'm not going to tell you many causes, but common things. What is staring to you? Hey, this is an uncontrolled heart failure, big PDA, big ASD. Then the second cause, could it be a Malaysian airway that's causing this problem? That's what Dr. Gan has highlighted because of an external compression, especially in a baby with a small chest, everything that's enlarged become very tight. And the third cause, he's been ventilated for some time. She has been ventilated for some time. Prolonged ventilation itself can cause parenchymal lung changes. And not forgetting that upper airway problems with prolonged intubations and all may result in upper airway obstruction and inability to extubate. So you also have to think out of the box, because usually clinicians like to think what is tearing out, but forgot about the peripheral thing, which may be a contributing factor. So I'm no cardiologist, but I would like to just tell you that the atrial defect and the PDA shunt, at the end of the day, we're talking about volume overload, right? Too much blood. The PDA, the patent ductal arteriosus, the blood that flows to the lung goes right to the right side of the heart, and the ASD that go to the left side of the heart. So at the end of the day, when there's too much blood for this baby's heart, there will be a volume overload, and this volume overload will cause usually a chamber dilatation because of the stretching of the muscles, right? And the heart gets stretched. Two, remember, like this baby also have gut problem and so on. So the doctors just steal the blood from to other organs, and it can cause organ ischemia, especially to the gut and the kidney. And as illustrated in this particular baby, she had infection of the gut. It's very important to understand the basic of the pulmonary overcirculation to the different organs. And here our concern also is to the lung, because you know the excess blood that flow to the pulmonary vessels will cause interstitial accumulation of fluid and causing the wet lung, and the fluid will build up within the interstitial spaces. And just hang on. So this will cause, you can't see this, never mind. And this will cause the lung to become very stiff. At the same time, because of the flow of the pulmonary vessels, when we talk about pulmonary vessels, you remember the small pulmonary vessels is traveling together with the small bronchus. It also compresses the small bronchi or the bronchioles, and that can cause compression and cause airway collapse. And that will result in the ventilation perfusion mismatch. So the insult, like the intubation, the flow, the infection, will also cause vascular remodeling, where there will be vessel thickening, the pulmonary vessel thickens, it can cause pulmonary hypertension. And what we don't want is that the decision is too late, that, you know, the patient develop reversal or shunt and isomangle, which I think that is something that we should really avoid and recognize early. So when we look at the cellular matrix of the ASD and the PDA, remember the atrial septal defect, the shunt is more on into the right side of the heart, and the PDA is more on the left side of the heart. So the primary pressure exposure in ASD will be is low compared to the PDA, which is very high because it's from the pulmonary artery and the aorta. The ASD, because the flow is much more on the right ventricles, it causes a high volume strain as compared to the PDA. The left ventricle is much more stressed by the PDA, the high volume strain, which causes the dilatation and failure. Then the injury to the pulmonary will be a bit more mild in the ASD, slow progressing, but because of the high velocity in flow, there will be a high velocity injury, and that will be much more severe. The smooth muscle injury is very minimal until late adulthood, but PDA, it will be rapid. It causes early thickening of the vessel wall. So in this particular baby, she had both. So this is a double jeopardy for this particular girl. So all this, because the shunt is quite significant, no matter how much you control with your anti-failure drug, but I think there is still quite one of that reason, because the shunt is quite significant, the failure could be uncontrolled as well. I mean, that's from the one of the reasons. The second point that I would like to discuss is about the Malaysian airway. So again, just now, Dr. Gan did talk about the airway compression, because in a PDA, there is a volume overload and high pressure to the pulmonary arteries that can cause the pulmonary trunk and its branches to dilate. If you look in this particular photo, that's the left pulmonary artery, and behind that, that's the left main bronchus. So they are very near, close to each other. So if this is a high pressure area, and if it's enlarged, it can compress on the left pulmonary artery. It may not cause stenosis, but it can cause airway narrowing from above, because it sits right up there. Now, in the PDA, also the left atrium can be enlarged due to the massive blood emptying from the lung to the left atrium. And you must know that the anatomy of the main bronchus is right under the left atrium. So it can sit on that, and it can also flatten the airway. So these are two contributing factors. Mainly, you see it on the left side. That's why if you look at the X-rays, you find that there are a lot of collapse, and mainly you see that more on the left, if provided that the patient does not have any active infections and so on. Now, the third effect is parenchymal lung changes. The interstitial edema, the high flow volume to the lung, will cause, over time, will cause chronic fluid extravasation. And that causes the persistent swelling within the alveolar septa. So it will cause septal thickening. If it is prolonged, it can cause fibrosis due to the long-term mechanical stretching, collagen deposition, and that cause the stiffening of the lung, causing reduced compliance. And you find that's where the issue is higher work of breathing, harder difficult ventilations, and so on. So this is one of the effect on the parenchyma. The other thing is on the alveolar growth, because this is a 35 weeks old baby, remember that. So a severe or long-standing left to right shunt can also disrupt normal postnatal development. The lung develop fewer and larger and less complex alveoli, and the air trapping will cause loss of compliance, hyperinflation, lung collapse, and also remember the nearby vessels that could also contribute to the problem. So I just want to show this CT thorax. This is not a CT thorax of this particular girl, but a CT thorax of another girl who had a complex lung, a complex cardiac long-standing. And what do you see the effect on the patient, on the child? So you see both hyperinflation of the chest. You can see different areas of perfusion, all right? Usually if you look, you think the darker one is the normal one. No, the darker one is not the normal one. This is not perfused well. This is the normal one, all right? And then you can see the thickening of the wall of the airway. You can see both. And when you look, long-standing injury to the lung from an uncorrected issues or whatever dynamics this child suffers has caused an impact to this particular, to this lung. And this is descriptive of what we say a bronchiolitis obliterative picture, all right? And a lot of these patients, when they present to you, especially after a viral infection, they present like someone who has an asthma attack because the airway can be narrowed, they cough, they wheeze, and you can hear bronchitis and so on. The treatment is still the same, but it's very fixed. The obstruction is not reversible to a certain extent. It's a fixed obstruction, one, and if it's quite bad, you may have a good heart control, but as a result of this, the child may require oxygen, or sometimes they will need non-invasive support, either a CPAP or a BiPAP. Like in this child, when the mother came and see me, he said, doctor, the lung is the problem. I need to do something on the lung. And I had a bit of hard time to explain that we cannot just look at the lung, but also look at the other component that her baby is suffering. So this is the summary. The heart is always in the center. So, the cardiologist and the cardiothoracic surgeon is to be respected because they are in the center. And you can see the lung is very small at the side there, and you look at the abnormality of the vessels and all come the other organs. So with due respect, we have to actually look and see how much of this problem can be corrected if the major contribution is the heart. So this is a summary. So a baby delivered high pulmonary resistance, but with time, the pulmonary venous will drop. The shunt will cause hyperemia, increase in the capillary pressure rises, interstitial edema, and all the mechanisms that impact the lung. Then you have the peribronchial compression, the vascular remodeling, and what we don't want is the vascular remodeling to go into irreversible pulmonary hypertension. The child may have pulmonary hypertension, but you want to stop at that. You don't want to progress because that gives headache to the pulmonologist, because the treatment will be much more higher and more complicated. Now, the final point, does this child have an upper airway obstruction, such as common subglottic stenosis? When a baby has prolonged ventilation, one must remember, upper airway obstruction, common, the subglottic stenosis, 90% is due to prolonged ventilation. Therefore, it's very important. I mean, the intensivist will tell you the tube shouldn't be tight. And usually I've seen from bronchoscopy finding is that when the ETT tube is not being stabilized, so that is a rubbing effect. The friction actually is very disastrous because it can cause mucosal ulceration, granulation, and scarring. So something to consider out of the box, but the risk is there in this particular girl. So let's look at the investigation. So you have the facts, you must understand the basic elementary of the left to right shunt. So we need to investigate. Actually, there's all the information are there. The x-rays are there, the CT scans are there, the bronchoscopy report is there. I did see, I think, in the slide, in the one that I didn't show it because I think it was just a picture that I couldn't load it. But if you look at this particular x-ray, you find this is a big heart. Of course, everybody focus on the heart. But look at the rest. Many reasons you can say, look, is this uncontrolled cardiac failure? Is that an infection? Is that interstitial changes? You can see all these peribronchial opacities here, you know. So definitely, if you look with the background and then you look at the ETT tube, I couldn't see, the airway is a bit difficult to see from here. So one reason, if you look at this x-ray to say, that's the reason you can't extubate this patient, not ready. That's one of the words you like to say. Dr. Ang has done the echo and he concluded that this is a large ASD and a moderate PDA with pulmonary hypertension, almost near systemic, not yet reversal. So this is a very important fact. Thirdly, this is a CT scan. Now, this is the CT scan that was done in the previous hospital is very good, actually. And it was done, I mean, credit to the radiologist there, who is actually a trained radiologist in cardiac radiology in IJM. So if you look at you just look at the parenchyma. So the parenchyma are not 100% normal. You have the interstitial, not as bad as the CT scan that you saw earlier. The heart is big. There are some area of consolidation there. If you look at the vessels, this is the pulmonary artery and the bifurcation, the left and the right. So this is the bifurcation of this is the carina. This is the right main bronchus. This is the left main bronchus. So it looks, because CT scan sometimes it gives you the dynamics as if it has been compressed. But you look at another slide, you see that there is a narrowing there, and then to the lower lobe here, or upper lobe, sorry. So yes, there may be a compression, but is that the only reason for this child, for this baby, not to be able to be extubated? That is what you need to ask. So, but I discussed with our pediatric radiologist, very important. When the cardiologist say I couldn't see any vascular ring, we go back and look at the CT scan. There is no vascular ring or aberrant vessel. The pulmonary artery is enlarged. A bit of narrowing of the left main bronchus. The right is fine. That's not an issue at all. So if you look at the data, you find that airway obstruction in children with congenital heart disease, and I see that very common. Children with cardiac disease, either ASD, PDA, or BSD that cannot be extubated, or persistent left lung collapse, and so on. So it's quite common, and you know it's at the left main bronchus, and that's because of the relationship with the pulmonary artery, with or without left atrial dilatation. So it could be just bronchomalacia, it could be stenotic if it's too tight. Sometimes tracheal stenosis, if you have a trachea, usually you want to see whether they have vascular rings or any abnormality of the tracheal structure. Okay, this is now, this child had a flexible bronchoscopy, but that was done in another hospital in the north. And I read the report. The report says that there is no, I look at it, I think it has, there was no stenosis. There's no tracheal stenosis. The bronchus look a bit narrow, but it's not stenotic. So this is just a picture just to show flexible bronchoscopy. You can see that. That's the compression from the left pulmonary artery. And if you scope, if I were to scope this child, I didn't want to repeat the scope unnecessarily for this. And you can see that this is what you see. And sometimes you will see the pulsation like that. All right? So when you see that, and if she is quite, it's not the whole airway. Usually, if you go lower, you can go through the narrowing, and usually you will find that this will be normal. There's no more narrowing or Malaysic of the airway. So, possible cause of failed extubation. Uncontrolled heart failure. When I saw this patient, I look at it and I say, automatically, something has to be done. Yes, because the shunt is very, very significant. It's not one, and if you remember what I say, the effect of the ASD and PDA is a double jeopardy for this particular baby. Prolonged ventilation causing chronic lung changes, it is a contributory factor. I wouldn't say it's not. It's yes, because of the chronic changes, the dynamics, as we understood the effect, because it's been months that this child was being ventilated. And it's not just the heart failure, it's not just that. The recurrent pneumonias itself can cause chronic lung changes. The ventilation, the pressures, and so on is also a confounding factor. Malaysic airway due to prolonged ventilation or external compression from the pulmonary artery, yes, it is possible. But I wouldn't say that's the most contributory main factor for this particular girl. And upper airway obstruction, such as subglottic stenosis, definitely is a no for this particular baby. Therefore, so what is the verdict? I said to them, this child, you need to close the PDA and ASD before more insult to the lung, or more insult to the lung that's causing lung damage, because if you do it too late, the lung gets more damage, and then you find the post-op management will be much more complicated and more expensive for this particular baby. And you want to do it when the child is stable, once everything is under control, because the longer the child had a intubation, infection is something that can always happen all the time. So from the pulmonologist's point of view, I would say, please close the ASD and ligation of the PDA. That I will leave to the cardiologist to decide the time with the intensivist, because they are doing the acute. I'm giving the opinion of what shall be done, to do it and not to wait, because of all the risk factors that this child had. And true enough, you see that the baby got better, and you find that once after you cannot just off to oxygen. Why? Because for the physiology to return, the Malaysic airway, the pulmonary artery to get smaller, the parenchyma to heal, it needs time. So that you can understand why the patient, when extubated, does not actually go to just air, oxygen, but can go to non-invasive support for a few weeks and finally off the non-invasive and without oxygen, which is good that we have made that decision and no further insult on the lung. And that's the end. Thank you. And I will leave a quote from Sherlock Holmes. How often have I said that when you have eliminated the impossible, whatever remains, however improbable it is, must always be the truth. Thank you.
Thank you very much, Dr. Nozida, to further illustrate the case. Yeah, so we leave the question until the end. So we need to welcome the third speaker, Dr. Ahmad Salehuddin. Okay, is our consultant pediatric cardiac surgeon. Okay, Dato is a graduate from New South Wales, Sydney, and obtained his FRCS from Glasgow and Edinburgh. He further get his training on cardiac thoracic surgery in Mayo Clinic, USA, even before I enter medical school.
Thank you for reminding my age.
He's a consultant pediatric cardiac surgeon in IJN and heading the team until 2002. And unfortunately, we lose him to Middle East. He went to Middle East for past 20 years, Saudi, Kuwait, and Qatar. And very fortunate he come back to us again to help our children with congenital heart disease. So please welcome him for the third talk.
Thank you, Dr. Ang. Thank you for the kind introduction. Thank you for the committee for inviting me to speak to you today. And thank you all for coming here to join us in this beautifully organized symposium. I'm going to talk to you about common congenital heart diseases that require surgery. Beyond what you've already heard, the patent ductus arteriosus and the ASD, there are other conditions that can benefit from cardiac surgery. How do you move this on? So the outline for my talk today is we'll go through some of the common lesions, focusing mainly on the time for referral and for intervention. We'll talk about some common conditions like the PDA you've already heard about, coarctation, ASD, VSD. I will also talk about atrioventricular septal defect and the Down syndrome, in which it is quite common to find this condition. We'll touch on some cyanotic conditions and talk about some emergencies that require immediate cardiac surgery. And then maybe we'll touch on some of the outcomes and give you some guide on how to, when to refer these patients for intervention. So, congenital heart disease is actually one of the commonest congenital lesions that affect children. So about for every 1,000 live-born children, 8 to 10 would have congenital heart disease. And a quarter of these patients actually require intervention within the first year of life. So that's a large number. Fortunately, the outcome is quite good these days. Overall, the mortality from intervention is less than 5%. And mortality is quite predictable, and in modern cardiac surgery, it is very low. In some situations, it's 0% mortality. So the limiting factor usually is the delay in presentation and the delay in referral. Just a simple murmur can lead you to find conditions that are quite dire that require intervention. And most often, it's just an echocardiography that can detect these lesions and lead the patients to referral and intervention. So when in doubt, always ask for an echo. So we need to intervene early because there are downstream effects of this condition that needs to be avoided. You've heard about pulmonary disease, interstitial edema, bronchiolitis obliterans and all that, but there are other things like growth problems, feeding problems, recurrent infections, and more problematic problems like endocarditis and arrhythmias and embolism and stroke, all that. So we need to intervene before all this becomes a problem. So the common cyanotic lesions that we'll talk about today, you've heard about patent ductus arteriosus and the atrial septal defect. We'll also touch on coarctation and ventricular septal defect. So the patent ductus arteriosus is the persistent aorto to pulmonary artery communication that remains after birth. It causes a left to right shunt, and as you've heard, it causes pulmonary overcirculation and left heart dilatation. In preterm infants especially, it's a major problem because it can lead to bronchopulmonary dysplasia. So the indications to close is usually we can treat these conditions with medical therapy, with indomethacin, ibuprofen, or even paracetamol. And a lot of these patients, the condition can close, the PDA can close. But sometimes it is contraindicated in some patients due to renal problems or other problems. So, and when this patient is very symptomatic and in respiratory distress, and as you've heard, on ventilator and failed extubations and all that, so this becomes an indication for surgery. Most often, these conditions can be treated in the cath lab, and you'll hear about this from Dr. Lim after this, that the PDA can actually be closed using a device. But not all conditions are suitable, and when the anatomy is not suitable, then we need to refer these patients for surgery. In preterm infants, if you delay this beyond 2 weeks, there is almost 70% chance of developing broken pulmonary dysplasia. So refer when the patient is on respiratory support or in uncontrolled heart failure, or when medical therapy is failed or contraindicated, or when the duct is not suitable for device closure. What we do during surgery is through a thoracotomy. This diagram here depicts the left thoracotomy. It's much smaller these days, and we spare the muscles. We don't cut the muscles. We go through the auscultatory triangle and dissect the muscles without cutting them. And the duct is either ligated or divided. And these days we have devices like the Liga clip, which we can just easily put onto the duct within seconds, and the patient can be out of the operating theater within less than an hour. In very bad situations, or in patients who are very, very sick, sometimes we can even bring our team to the NICU and do the procedure on bedside, so without having the risk of moving a patient who's on ventilator support from the ward to the OT, we can actually do it bedside. So the next lesion we talk about is coarctation of the aorta. The condition here, there are two presentations. There's one where the patient presents with severe heart failure right after birth. And these patients, when they are found to have coarctation, they're usually supported with prostaglandin to maintain the PDA if there is there, or sometimes even the prostaglandin can cause some relaxation of the coarctation area, and they can release some obstruction. But in general, these patients require surgery as soon as possible. This is one of the remaining emergencies in cardiac surgery. But the other group usually presents a bit later in life, where it is found that there is a radiofemoral delay in their pulses, or they can even more delayed that they develop hypertension. We don't want patients to go into that stage, but once it's diagnosed, usually can be electively scheduled for surgery. So in the neonatal obstruction is quite urgent, but in elective cases, preferably is done during infancy, because we have data from audits from around the world, where if the patient has surgery beyond the infancy, there is a risk that the patient may develop systemic hypertension later in life, and the mortality from the operation is almost zero these days. This is what we do. We cut the duct and remove the coarctation area, and we extend the incision into the arch. Usually there is some hypoplasia of the arch, and also it increases the area for anastomosis. This is referred to as the extended end-to-end anastomosis, and this is the surgical picture of that operation. So, and again, as I've said, mortality is very low, survival is very good. And if there is some incidence of recurrence in these patients, so you need to follow them up quite long. 5% we can treat them in the cath lab by interventional cardiologists, but sometimes about 2 to 3% of these patients require a second operation. As I've said, some patients develop hypertension despite repairing the coarctation, so we need to repair them early, and we need to provide lifelong surveillance. If they have already had this surgery repaired in their infancy, that they may eventually develop systemic hypertension. So symptomatic neonates, you need to treat them early. There is some form of hypoplasia, also needs surgery. If they are in congestive heart failure, especially if there is poor left ventricular function. In the older patients, if there is a difference in the blood pressure of 20 between the radial and femoral, or a peak gradient of more than 20 on echocardiography. And this is a very late presentation where there is a rib notching. We don't see much of this these days because these patients get operated or intervene much earlier in life. The ASDs, you've heard the secondum ASD from that patient that we discussed by the two previous excellent presentations this morning. But there are other types as well. The secondum is the most common. There is the primum ASD and the sinus venosus ASD. Secondum is the most common. Most of the time it is also closed by the device, but sometimes the rims are not well formed that the device may not have enough for purchase. So these patients are referred for surgery. Primum ASD is actually a part of AVSD or atrioventricular septal defect where there is no ventricular component. And these defects are not amenable for device. They're usually associated with a cleft in the mitral valve and also mitral regurgitation. So most of the time they require surgery as well. The sinus venosus ASD is a high VSD that's often associated with anomalous pulmonary venous drainage due to their location. And although I say here that device is not an option, but it's increasingly that the interventional cardiologists are closing these ASDs using covered stents. It's not happening yet in our country, I don't think, but it is coming. And what we do is a surgical repair. So secondum defect is the candidate for device, but if it's other defects, then most of the time it's for surgery. So when do we refer these patients? You've heard infants when they are in heart failure, they are on ventilator, they cannot come off ventilator, they fail extubation, and they're suspected to have pulmonary hypertension, then that is the time to have the ASD closed. Most often than not, it's in children. They present to us because a doctor heard a murmur when they present with fever or respiratory infections, and then referred to the cardiologist for echocardiography and found a defect. Usually, in this group of patients, we advise the family to have the defect closed before they go to school so that their schooling and education is not interrupted, and also that they do not develop pulmonary hypertension. More often as well these days, still, there are adults who have been missed because the heart and lungs are very strong organs. Even if you have a large defect with a large shunt, the patients can go throughout life without any symptoms, and it's only found when they go for a medical examination for a job or go to university, or when a lady gets pregnant and it's found that they has. So in these situations, it's usually indicated immediately that if there is heart dilatation or if they have developed arrhythmias, then the ASDs, the atrial septal defects need to be closed. The third defect is the ventricular septal defect, another common defect found in children born with congenital heart disease. The perimembranous defect is the commonest. In our region, the doubly committed subarterial is also quite common. In fact, it's up to about 15 to 17%. The Westerners don't quite see these defects, but here in our region, it is one of the commonest defects. The muscular defect is also another common defect. It has the potential to close on its own. So usually you can observe this for a while, maybe a year or two, and see whether they can close. If they can't, then they can either be closed by the device or surgically as well. So these are the different kinds of defects that you can see here, multiple. We won't go through all of them. But operative mortality for VSD closure, if it's done in a timely manner, its success is 100%. Mortality is almost 0%. In fact, it is 0%. There are complications like requiring a permanent pacemaker, less than 1%. And sometimes the patient has a residual VSD either at the same site or maybe another site, then they require surgery at around 2%. So again, it's essentially zero mortality, so you need to refer them before the lungs are damaged. What we do is we close them with a patch, and this patch is made from expanded polytetrafluoroethylene, or more commonly known as Gore-Tex. We use either continuous sutures or interrupted sutures as shown here, or a combination of interrupted and continuous sutures. Nowadays, most of the time before this, we do the surgery through the median stenotomy. The ASDs and the VSDs, even still tetralogy fellow, we do them through the median stenotomy. But now, with patients who are more than 5 or 10 kilograms, we can actually do them through a small incision under the armpit. We do the same operation, same procedure, same outcome, in fact, better outcomes, because the patient can actually get out of the ICU in the hospital much earlier because the sternum is not cut. Because the sternum, when it's cut, it's like a fracture of the bone. It takes about 2 to 6 weeks to recover. And then there's also potential for bleeding and infection. So with this new technique, it is quite preferable both to the patient, the family, and also to ourselves, because the outcome is quite good. And we offer this now a lot to our ASDs and VSDs. In fact, we are moving on to valve repairs and also tetralogy of fellow as well. And the exposure is almost the same. As you can see here from the thoracotomy, it is quite wide. You can see the atrium, the ventricle, and vascular structures. And this is the ASD that we can see through that access, and we can do the same operation as if it was through the median stenotomy as well. Atrioventricular septal defect can be partial and complete. We've talked about the partial AVSD, which is often referred to as the primum ASD, but more commonly it is the complete form, and it's commonly found in patients with Down syndrome. We've talked about partial AVSD. Typically, we don't operate on them in the first year of life because the mortality is a bit higher when you do that. So we wait for them to be around 2 to 4 years age. Unless, of course, if they have a mitral cleft, which has resulted in severe mitral regurgitation that you need to repair both at the same time. Prognosis is also quite good. For the complete AVSD, there is a defect in the common AV junction. So you get a single valve and a large hole in between. And 50% of Down syndrome have this condition. So if you have a patient with Down syndrome, it is actually beneficial for you to send this patient for echocardiography, because 1 in 2 of them will have an AVSD. And the timing for this procedure is around 3 to 6 months. We don't operate on them before 3 months because of the mortality, and also because we need to repair the valve of these patients with AVSD. And before 3 months of age, the valve structure, the tissues are not well formed. So we need to wait for them to be around 4 to 6 months when this tissue has already firmed up and the repair is much better, because the outcome is very good. The mortality is very low. Mortality from this condition is not a problem anymore these days. What the problem is the residual incompetence of the left AV valve that remains with the patient and makes the patient require a reoperation of about 9%. So to reduce this incidence of residual mitral regurgitation, we wait a bit longer so that we can do a good job on the mitral valve and get a long-lasting repair. So as I've said, we have to reconstruct the valve. This is the left AV valve. There's usually a cleft, and we repair that during the repair of the AVSD. You've heard about single patch, 2 patch. What we do nowadays is just a single patch. We suture the valve to the crest of the ventricular septum, repair the cleft, and just put 1 single patch onto the defect. Sometimes, as I said, those patients who are less than 3 months, they still need something to be done because they can present with severe heart failure and uncontrolled heart failure, but we don't want to operate on them before they're 3 months because their valve is not well formed. So in this situation, we subject them to what we call pulmonary artery banding, which is a temporary condition that limits the overflow of the blood into the lungs, so that this patient can then get out of heart failure. If they're on ventilator, they can even be extubated and sent home on room air. And then they can allow to grow, feed and grow, and to a time when they're about 6 to 9 months, when their weight is more than 3.5, 4 kilograms, then it's time for us to unband the patient and then repair the valve and get a good result, not only in terms of mortality, but also in terms of longevity, the durability of the repair for the left AV valve. Now we move on to a condition which is a cyanotic condition. The previous conditions were all acyanotic. This one, tetralogy fellow, is the pathognomonic of cyanotic heart disease. These are your blue babies. So as you have known from the term tetralogy fellow, there are four conditions in the one. There is the VSD, there is an aortic override, there is right ventricular outflow tract obstruction, and hypertrophy of the right ventricle, which is depicted here in the surgical specimen. Patients usually present with cyanosis, and on X-ray you can see a boot heart. But if they present late, sometimes you find conditions where patients have a clubbing. This is clubbing of the fingers, and the patient is no longer cyanosed here because this picture was taken after he had the surgery. So his cyanosis is gone, but the clubbing will remain, but it will go away with time. Again, like the AVSD, when this patient presents too early in life, especially in the neonatal period, the outcome of the total repair for tetralogy fellow in this group of patients is very high. So in those situations, we put a shunt to improve the blood flow to the lungs and reduce the cyanosis, and then operate on them when they're about 4.5 to 6 months of age. The repair involves the closure of the VSD, and then we widen the right ventricular outflow tract that's obstructed. As I've said, 6 to 12 months is the appropriate time to do it because the mortality in the neonatal period is high. In this group of patients, it's only 0.5%. The problem with this tetralogy fellow is that you need to follow them up for life, because once you've corrected, enlarged the right ventricular outflow tract, there is a residual pulmonary regurgitation. Most patients can tolerate this for a long, long time, but there are patients who start to develop right ventricular dilatation. And so in this group of patients, we need to be aware that they will need pulmonary valve replacement to restore the competence of the pulmonary valve, as well as cause the right ventricle to get back to its normal size. These are all, most of them are elective, as I've said, as one emergency situation where the patient presents with heart failure. There are very few remaining emergencies in cardiac surgery these days due to the expertise of the intensivists and the cardiologists. One other emergency that I would like to mention is the obstructed total anomalous pulmonary venous drainage. I do not discuss it here because these patients require surgery within 24 hours. So, but most often it is missed because they present to ICU and intensivists or the cardiologists or just regular doctors at the ICU will think that it is a persistent pulmonary hypertension. As you've heard, they usually blame the lungs and then find out later it's actually the heart. And by that time, what we get is the referral is 3 to 4 days. 3 to 4 days makes a lot of difference in these patients because the mortality is almost 100%. So hopefully, if there is some form of pulmonary hypertension which you cannot explain when the patient presents the first day of life, then do an echo, because echocardiography can detect obstructed TAPVD. You need to send the patients here as soon as possible because surgery needs to be done. The term that they use is before the sun sets. The other emergency that we can have more time to work on is arterial switch, or the TGA, transposition of the great arteries. These patients present with cyanosis at birth and with a normal X-ray, normal heart size often. But then you need to figure out why they're cyanosed, and you do an echo and you found that they have transposition, which is the aorta coming from the right ventricle and the pulmonary artery coming from the left ventricle. These patients are in a certain way also in an emergency situation where you need to have their arterial switch operation, which is to switch the great arteries back to their normal position, done within 14 days. That's the average. But most of the time, by the time they need to be referred, prepared, monitoring problems and all that, they usually come to us within the first month of life. That is not preferable, but that is what's happening. But if you can help get them to the hospital before 14 days of life, because if you do that, the mortality is 1%. In fact, now I also work in this Institute Jantanegara. One of our KPIs is that this disease should be 0% mortality today. And the survival is more than 95%. So, in summary, patent ductus arteriosus, there is failed medical therapy, all those indications. It's often sometimes urgent, but in most situations it's elective. Coarctation of aorta, as I've said, there are two groups, the urgent one in the neonates, elective more in the infants. ASDs, usually elective, but there are situations where it can cause a lot of problems in the early period, then they need to be done as well. PSDs are often, more often than not, it's an elective, sometimes they are semi-urgent. AVSDs, preferably between 3 to 6 months. If they're still heart failure early, then you have to do a pulmonary artery banding. Tetralogy of Fallot, again, neonatal surgery is high risk. We do a BT shunt in the neonates, and then those other patients are, and including those patients who had a shunt, will be operated on when they are around 6 months of age. TGA, or transposition of great arteries, get them to the hospital within the first 2 weeks of life. Operative mortality, as I've said, is very low nowadays. 0% for PDA, around 3.7% for AVSDs. So across all major congenital heart disease mortality is very, very low at experience centers, including Sunway Medical Center here. And early referral is the thing that can modify the outcome. Early diagnosis and early referral. So in summary, diagnose early, most often than not, echo is enough. If you can have access to the CT scans and all that, yes, but clinical plus echo can get you 99% of the time to diagnosis. Refer early, timing is very essential. Those patients who have a duct, like the coarctation, or some PDA, or some tetralogy of Fallot, you might sustain them on the PGE for some time, but get them to the hospital where surgery can be done. Down syndrome, echo them. Half of them will have AVSDs. Need to refer them so that they get the condition sorted out before their lungs get damaged. And also important, it is not one single intervention that can resolve the issue. You need to have these patients followed on almost for life, unfortunately. But it's for their own benefit, because there are problems that can happen later on, and also additional associated conditions that needs to be detected and addressed. So I think we leave the questions to the end. These are the references that I've used for my talk today. Thank you very much for your attention.
Thank you, Dr. Ahmad. So he's a very good surgeon. Please refer more case to him. So next we come to the fourth talk, beyond surgery, the evolving role of device closure in congenital heart disease. So let me introduce Dr. Lim. Dr. Lim Wee Kok is a graduate from University Science Malaysia and obtained his MRCPCH. Then continue his pediatric cardiac training in Sarawak Heart Center, IJ, and also Birmingham Children's Hospital. He also obtained his fellowship in MRI, fellowship in Society of Cardiovascular Magnetic Resonance, and he is the pediatric cardiologist in Sarawak Heart Center for the past 10 years before joining us. So please welcome him for the fourth talk.
Thank you very much, Dr. Han, for the kind introduction. Speaking after all the great lectures and the giants before me, and keeping you guys before your next tea or your early morning tea will be a daunting job. But let's talk about something that, can we change the slide? So this is something that maybe something that we are going quite new for the last 20 years. Surgery remains one of our pivotal arsenal we have against congenital heart disease. So as you can see on this screen, we have multiple devices that looks like a lot of umbrellas. So if you cross the road, you hit a bump, then you look at the road, hey, is there a Unify or a TMB metal? It looks like it's something like that, okay? So our objective is to describe common congenital heart defects that we can use to close with devices, compare it versus surgical, identify suitable patients, recognize potential complications, long-term follow-up needs, and also understanding hybrids. Also, we are also exploring, or we are actually having these things now, hybrid. Means the surgeon and the cardiologist go in, interventional cardiologist go in into the OT and do it at the same time. So again, what Dato has mentioned in his previous slides, congenital heart disease is very common, 8 to 10 in 1,000, basically 1%, as simple as that. 100 mothers delivered today in Sunway, one will have a congenital heart. It's very high. Imagine a busy hospital, antenatal center that has 12,000 births per year, means 1,000 per month. At least 10 has congenital heart disease. So it's quite high if you compare to all the other things. And as usual, the most common congenital heart disease, if you remember your textbooks, is still your VSDs, ASDs, and the PDAs. Okay? So what does transcatheter closure mean? It just means that it's minimally invasive as alternative to open heart. Okay? And it's usually done in the cath lab. Usually, I just say usually, okay, and commonly done. But we can still do it in other places, as especially baby who are very weak, very unstable, and sometimes we can do it on the bedside in the NICU. So actually we do PDA closure in the NICU nowadays or PCU. That can be done and can be arranged. No issues about that. And this actually avoids open heart surgery. You don't need to go through cardiomyopathy bypass, and usually requires only 1 or 2 days. So for those elective device closures, and sometimes we don't do this for small children. Same day discharge is possible, but not all. So if you see the evolution of catheter devices that has been invented, so in 1976, they did something like this. It's a radial umbrella. In 1970, King Samuel performed the first experimental transcatheter ASD device closure. And as you can see, throughout the years from 1976 until 2025, development has continued. People have started planning and also designed a lot of devices. So in 2025, ACC, AHA, we actually formulated integrated transcatheter approach as a standard care. So FDA actually approved this small little device, it's a Piccolo device for PDA, closing PDAs for babies about 700 grams and above. Yes. How big is this device actually, if you were to ask? Sorry, never mind, you go for it later. So the first one that I will talk about is ASD. As Dato mentioned just now, 75% of patients who have ASDs, secundum is suitable. And the others, like primum, fundus venosus, we do not touch. Some interventionists who have very big appendages still go for sinus venosus. They are exploring that, but not many. Okay, if you can see this diagram, the ones that usually is amenable is this right in the middle, right in the middle. Sometimes they may have aortic rim division, but we still can close it. But there's also a risk that it may slip out or it will dislodge. Okay, and usually, as you can see, indication is still numbers 1.5, RE volume overload, history of product. This one will be more for those young adults with suddenly stroke, spiral dorsal embolism. So again, primary ASD, sinus venosus, and coronary sinus ASD, ask the cardiothoracic surgeons. So transcatheter ASD closures, if you compare with surgical closures, you can see surgical closure, they get 99. Transcatheter get 95. Why? Because you can plan to do it, but you do not have full access. You can't see unless you have very good imaging to go in together, and you can plan well, and you can put the device well. Okay? Sometimes you may not be able to see the whole anatomy well unless you get the full picture. So it means you may do a transthoracic echo before patient goes into the ICL. You do a TOE, but sometimes you may miss some other things, or you see something, oh, this patient is not amenable. This patient has other things, so we cannot do it. We need to come out. We need to send to the surgeon or plan for CT scans or MRIs later on. Okay. Hospital stays obviously is shorter, 1 to 2 days. Complications less than 5%, but if you see surgical, maybe some bleeding and so on, but I think it's very minimal now. Arrhythmia very low. effusion even lower. Groin puncture is the one that usually we will need. So usually we approach it from the groin, okay, usually from the right side. So there's no bypass. Saying that pericardial effusion is actually something we have to be very careful about. I did have an unpleasant experience. We closed an ASD in a patient who previously had radiotherapy done. Okay, so we closed it. 5 minutes later, patient suddenly heart rate dropped, BP collapsed. Why? Patient developed pericardial effusion on table because we actually caused pericardial effusion as we put in the device. We actually rub and we actually caused the bleeding on site. Okay, so that is something we have to consider sometimes. So for interventional cardiologists, we just have to be careful. We just have to get ready at all times, just in case patient collapse on table. You will know what's happening. Okay. So this little animation cartoon just shows us how it is done. Very simple. We put in a catheter through the femoral groin, put in a wire, cross it, and usually it's done through fluoroscopy. Put in a balloon. Some centers don't use a balloon. The way I was trained, we don't use balloon. We use this transthoracic echo, esophageal echo to do balloon sizing. As you can see this. Then we inflate it, we deflate it. Then once we know the size, then we select the device that is appropriate. And once we cross it, we will unshift the device. So it's just like umbrella, two device. That means two-sided device where we open up one side on the left, then we pull across and we open up from the left or the right. Then we will do a shaking test to make sure it is stable before we release the device. Okay? So it's very essential when we pull and we make sure it's stable before we release. And we need to do a transesophageal echo to confirm that it's in situ, it's placed well, and there's no risk of dislodgement. I would say no risk, I would say 100%. Okay? So don't be fooled that this is 100% because it may still dislodge. Okay? So after 6 months, usually in endothelialization, it is gone. Okay? So endothelialization happens after the device is put there because if it works like a scaffolding. So the device will become a scaffolding for the tissue. So transcatheter, if you compare to surgical, again it's the same thing. Why go back? Okay, so again I show you a video. Just now this is a live angiograph. So you see the device is being deployed. The first one actually is not in place. So the person actually discovered, we do a second time, pull back. And now you see, we are actually pulling and pushing, whether it is stable or not. It's very important. If you don't do that, we release the device fly to somewhere else. Then we have a fishing trip for the next 6 hours or call Dato to come and fish for us. Okay? So to do interventional cases, we must always have surgical backup at hand. And we are lucky to have a cardiothoracic surgeon on standby at all times. Okay? So, this is again the same thing. Okay, so large defects or non-circumferential subtype require surgical intervention. So 38 is a limit, but sometimes some interventional cardiologists will say, no, we can go further because the device is there. The size of the device is there. Okay, but it's very dangerous. And we also got septal rims. So if your rims are inadequate, do not attempt. If the rims are inadequate, I will not attempt because you're just getting yourself ready to fish the device out for the next 6 hours or get the surgeon in. And the most important is subtypes, recognizing non-circumferential subtypes. If you can identify from the start, please don't attempt. Okay? And other anomalies like partial anomalous primary venous tissue, especially for sinus venosus style ASDs. Okay? Obviously, before we close any ASDs, we need to make sure that the PA pressures are low. I do know that sometimes holes are meant to be closed, but some are not supposed to. You have to make sure the PA pressures are supposed to be measured before we close the hole. So that is very essential. If you are from a pediatric cardiology training, you will know that PA pressures has to be checked before you close the PDA or even the ASD. If you close it when the PA pressures are elevated, then you're asking for trouble. Patient will come back to you with pulmonary hypertension. Okay, so again, that's why we put here PA pressure, PVR greater 236 min, right to left shunting. Do not close them. Do not close them. So complications, yes. We see complications. Number one, this nice X-ray to show that the device is in the chest, but it went somewhere else. It went somewhere else. It has migrated. It went because it got dislodged. I've seen a device being implanted in the morning. They repeat an X-ray. Where did it go? It went up to the aorta. It got stuck in the aorta, luckily. So it had to be extricated. It has to be removed immediately in the afternoon. Okay? Again, this is another picture where the device caused erosion and causing cardiac tamponade. It rubs against the aorta. If you can see, this is a device. This is just the aorta, and these sharp edges actually are rubbing against the aorta and causes cardiac tamponade bleeding. Okay? There are cases already reported, so we have to be careful. Okay? So every time a patient comes back for assessment, cardiac echocardiogram has to be done. We need to make sure that there's no cardiac tamponade or there's no erosion happening. So the next thing that we always like is nickel, but it's quite rare for us to see any nickel allergy nowadays. So we need to monitor the complications that may happen in the patient post-device closure. Okay, sometimes after putting the devices, we may even cause atrial arrhythmia. Device may cause thrombosis because we should put the patient on antiplatelets. Some patients are not compliant. They forgot or didn't take, or when they get discharged, they didn't get the medication. Okay, and sometimes we have residual shunts, so we need to check on them. We need to make sure everything's okay. So VSD, that's another big group of patients. VSD is most common congenital heart lesions, 30%. And the ones that we always see, perimembranous muscular inlet and so on. 40% of those muscular VSD spontaneously close. So that's why Doctor also mentioned, we watch and wait, sit down, have a cup of coffee, tell the parents, oh, let's see what happens. Okay? But usually they close, luckily. Perimembranous, 35% of them close only, 35%. So you still wait, but we have to be watchful waiting. If let's say they are in failure, then we need to either get them on medications or intervene, namely surgical or transcatheter. So again, the numbers speak. We need to make sure if they have QPKS more than 1.5, then please go ahead, close it. LV volume overload, and most important, if there's any history of endocarditis, it is 100% requirement for closure. And this is not deviceable. Endocarditis, I will definitely straight away send to Dato. I won't touch. Okay? The paper just recently published in JAC 2026, I think, as I was preparing this lecture, Dr. Tin, Dr. Tin here from Vietnam, with cooperation with Prof. Sien Ho. They just published many types. Unfortunately, for VSDR, there are many subtypes of morphology. So it's quite difficult. We won't be able to 100% tell you whether we will be able to close it or not until we go in on table and then we try. So that's why when we counsel for VSD device closure, I cannot or we will not say 100%, we will try. Okay? Sometimes it's not in the middle, or sometimes when we close it, there's still some residual shunt. Okay? As you can see, the paper here, a lot of types, and there are many types of complications, many things that you can see. So this is two videos. This is LV angiogram, you can see here. This is the catheter, contrast going through. This is the VSD crossing it, so this is causing blood. The contrast to cross the LV to the RV. So this is the final effect when you put a device in. The contrast is being injected, no contrast flows through, or a little bit of contrast goes through because the device is still attached. So this is how the device will sit to close the VSD. Okay, this is an example, and this is actually the picture stills that they do in format. Okay. So VSD device closures, again, if you talk about muscular, usually they will close by itself. So not very much done, but if it's a big one, then we may attempt to close it. And especially so, muscular VSDs are quite common, not say common, muscular VSDs are seen in elderly group. Why? Because they develop acute myocardial infarct. So this is another group of patients that will be good for them, but unfortunately, patients with post-myocardial infarct have very friable muscles. So their VSDs are usually very big and they are friable. And the ones we attempt to close will actually give a very large size of the VSD device. Okay. So next one, PDA. Usually, our PDAs, as you advise them, they close between 1 to 3 days. And this closure failure results in left to right shunting, causing much blood flow to the lungs, volume overload. And I wouldn't say the heart fails, it's the lung fails because there's too much blood. It causes the problem and it causes overload to the lungs. The heart is working too well, okay? So then it causes a lot of problems to the baby especially. It causes increase in size and a lot of shunting. So it causes untreated, cause heart failure because of untreated ductal arteriosus. It will definitely lead to pulmonary hypertension and subsequently or ultimately causing pulmonary Eisenmenger syndrome if we don't cause it well, if you don't catch them early. So again, if you hear a murmur, please refer early. We get the echo done, 10 minutes settled, then we can decide. Rather than wait and wait and wait, I think it's a VSD, I think it's a PDA. No, please come and do it. Every time I see a patient with murmur, the first thing I tell them, I'm not Superman. I can't use my hand to tell you what is in your heart. I need to echo, okay? So again, 2 videos showing. So this panel is showing that the angiogram, the PDA is here. This is where the PDA closed, the device closed, and there's no much contrast flowing through anymore. This is a successful PDA device closure. Again, as I mentioned, we need to be very vigilant. We have to be very careful on the patients that we select. Not all patients are amenable to PDA closure, especially those large PDAs. Okay? PDA device have certain limit. It's a fixed limit because manufacturers beyond a certain limit do not manufacture. Sometimes devices that are meant for other lesions are being used for PDA. You'll be surprised. Okay, some VSD devices are used to close a huge PDA. Okay, those patients come usually when they are around 10 to 11 years old. Very big PDA. Okay, and these are actually the devices you can see. So the devices, they have detachable coils and Paeds. This is one of the ADO1, ADO2. This is the mini one. And also they have this is like coil. So there are many types now. Development, research, and so on. So how big is the piccolo, if you ask me? It's this small. Smaller than a €1 penny. $1, €1. So it's very small. And it's very, very soft. And this can be used for babies and 700 grams and above. Okay? So, and this can be done actually bedside. Okay? The interventionist with very gung-ho wants to do, I will say, please go ahead. I will assist you. At the moment, we are not doing here yet, so I think my manager will be very, very excited. Okay. So, hybrid procedures. So what does hybrid procedure actually mean? The surgeon actually opens up, then the interventionist goes in and put in the catheter and so on. We assist side by side. Okay, there is something that we will be, you can see now more and more most often. Okay, usually can be done hypoplastic left heart. Unfortunately, we don't do that much in this part of the region, or intraoperatively stenting for coag PA stenosis. So another thing that Dato mentioned just now, TOF, before surgery can be done, because baby sometimes too small, emergency, we cannot go in for theater, patient unstable. So we can do things like RVOT stenting or balloon angioplasty of the pulmonary valve. So if you see this is actually to reduce the construction, increase the antegrade flow or the blood flow to the lungs, promote systemic oxygen saturation, promote symmetrical pulmonary flow. So this is 3 little videos to show you. First one is the RV angio. You can see that the RV is actually hypertrophic, but the RVOT is very small, okay? And then subsequently, we deploy the stent across the RVOT, but that will eventually destroy the pulmonary valve, which the surgeon don't like. Okay? So we will have to think and discuss the surgeon, which one is better? We balloon first, put in a stent, or we do a BT shunt. You're always an MDT, as you can see, it's always an MDT discussion between the cardiologist, the surgeon, and even the PICU, and also a neonatologist, okay? So we have to think at the best interest of the patient. Hopefully this slide don't crash. Okay, so next one. Next thing that Dato mentioned also, after TOF repair, 10 years or 15 years after a TOF repair for a child who is 4 years old, 5 years old, now is 20 years old, we look at the valve, we look at the RV is dilated, RV is overloaded, we need to repair the valve, we need to change the valve, we need to change because the RV is getting bigger and causing a lot of issues. So there are new things that can be done. So one, previously we actually sent patients for pulmonary valve replacement through surgical procedure. But now there are also ways of doing it transcatheterally. So we can change or we can implant a new valve through the pulmonary valve through transcatheterally. So it can be done, and it's actually been done. It's starting to be done in Malaysia now. Okay, we have many successful stories also. So I can actually share to you. So one patient of mine previously in my previous center has a very big dilated heart. She was actually operated when she was small, 4 years old if you remember. Big heart, big RV now, big RV. So this is how you should see that the RVOT, pulmonary valve is implanted through this cartoon. So transcatheterally can be done. Okay? And nowadays, if you attend or in our cardiac conferences, people actually perform live and discuss about these cases across the region. So this, you can see, this team is from India. They were doing this case live in front of the conference, and they were deploying the device live. So it can be done. It's just that the complexity, but before we can do this, is actually a lot of work, a lot of background work, a lot of pre-planning, a lot of patient selection and discussion. Okay. Again, not all patients are suitable because the limiting factor is always the size of the lesion. Because the PA, the moment the pulmonary valve is so big, the aneurysm is too big, then we can't go in because only there's a certain limit of the pulmonary valve that the manufacturer has already manufactured, maximum. Okay? If I'm mistaken, it's about 36 millimeters. So if you see a patient pre and post valve implantation, so pre, I saw this patient in 2019, RV EDVI, so basically the bigger it is, the worse. So it is 299.7 mils or 160, it's big. Post pre-valve implantation in 2021, it became small and it shrank. So this is the pre-implantation. So you can see that this is RV, this is LV. The blood is flowing from the RV to the pulmonary artery and it's actually flowing back. Free flow, we call this pulmonary valve free flow. So this is post-pulmonary valve implantation, CT scan, and you can see how nice it is sitting there, it's capturing it. So this is something that is in the future or is happening now, but in selected patients, okay? In selected patients. Or sometimes what we actually do is we ask the surgeon to go in the first time to reduce the size of the pulmonary RVOT in preparation for the next 10 to 15 years when we can implant the device. So first time surgeon goes in, open up the RVOT, correct the TOF. In 20 years age, the surgeon goes in to reduce the size of RVOT, put in the new valve. In 10 years' time, if we need to go in again, at least the RVOT is not dilated. So it is like a joint venture. Who kicks the ball first? Who gets the ball first? Okay, it's always MDT. Next one, I think coarctation of aorta. As Dr. mentioned, there are few patients that present as emergency now. So one of it is coarctation of aorta. So if a neonate comes with coarctation aorta, prostaglandin is a must. Then we need to decide, go in first for surgical operation, or we can actually do something for the patient. Either we balloon it or we actually stent it. Balloon is usually for neonates. Stenting is for bigger children or bigger adults. Young adults. Okay? We can relieve it. So you can see these two pictures. Actually, for a patient of mine, tiny, very, very severe. Has a lot of vessels on the sides. Okay, this patient was about 9 years old. So 9 years old child with a BP higher than mine twice. Suprasystemic. So that's why important for you to check a BP whenever you see a patient in your clinic. For children, if you worry about heart, please check BP. I know it's very difficult to check BP for little children, but please, if you find that there's something wrong, please check the BP, upper limb and lower limb. If you can't check the lower limb BP, feel the pulse. Always feel the pulse. Okay? So that's my take-home message for you guys. Please check the BP, upper limb and lower limb. Because it is very essential. You don't want to miss a coarctation aorta. So example, if you put in the catheter, you see, this is so small. Then you deploy it. So the intervention will be like pushing, quick, deploy. Then after deployment, obviously, it is very nice. So you can see that it is very nice. And post-op or post-intervention, you can see the device or the stent is deployed well. So again, the last few slides, when do you refer a patient for intervention for cardiac? So again, murmur is very important. Patients with failure to thrive, tachypnea, recurrent chest infections, exercise intolerance, please refer. If you managed to get an echo done, that would be excellent. If you can't, please send us for echo. So we will also intervene and we will do intervention, or we take our precaution, discuss the patient when there's an hemodynamically significant ASD, VSD, PDAs, and we will intervene. Okay? So if you have data about echo, growth chart, feeding history, saturation, please send to us so that we can actually assess the patient thoroughly. And as a primary caregiver, we still need to send patients out back to the community. They're still on medication. So we will write patients, these patients are on this medication, example, aspirin, clopidogrel. Please make sure they are on. We tell them, this patient not supposed to go on this exercise. Don't run 6 weeks, don't play, don't fall because you're post-intervention, then you don't get your device crumpled and so on. Okay? And devices are sometimes not MRI compatible, but usually all the devices are actually MRI compatible, just that it doesn't give you a nice picture. I might do an MRI, when I see all these artifacts, like, I cannot see anything, okay? So, if you see a patient with new murmurs, syncope, unexplained fever, or panic, please refer as soon as possible. And last slide, bioabsorbable devices are coming. So these devices are there when you deploy them, but in 6 months down the line, you can't see them on echo anymore. Means they are resolved, they hilang, they can't be seen on echo, or they can't see on X-ray anymore. So bioabsorbable devices are coming in, already approved. They are coming in and they're slowly being expanded usage throughout the world. Okay? So that's why I ask patients sometimes, don't be too impatient to get your clothes. Just wait. In the next 5 years, who knows, you may get an ASD device which is bioabsorbable, and you will not see the device after 6 months of implantation. Okay? So beyond surgery, cardiac transcatheter device closure. First line, obviously, secundum, ASD, PDA, which are suitable. Surgery, always a backup. I always feel very comfortable if the surgeon is available anytime. VSD closures, expanding usage. Premature infants for PDA closures, yes, we can think about that. But complications are there. We always have to be careful. Erosion, thrombosis, heart block, and so on, especially VSD devices. I've seen a patient post-VSD device closure had heart block, had IE on the device. So we have to send to another center to be extracted and put in a pacemaker, unfortunately. So primary care role for you guys are very important. Refer, post-procedure monitoring, and long-term follow-up. And the field of transcatheter device technology is actually expanding exponentially. Okay? So I leave you with such images. One very nice image up here is an image of a ASD device. It looks like cloud, okay? But this is actually the whole image, so we can actually see the device when we do a or echography in the cath lab. Thank you very much.
Okay, Dr. Lim would appreciate if you can kindly remain on stage for the panel discussion. And also, we would like to invite all our other doctors, Dr. Nozila, Prof. Gan, and also our moderator, Dr. Ahad Lee, to stage to start with the panel discussion. Okay, before we begin our panel discussion, we would like to share a story that reflects the power of multidisciplinary care, collaboration, and hope. The infant was born prematurely at 35 weeks and initially recovered well after a short NICU stay. However, after a few months later, she experienced a life-threatening episode at home where she suddenly stopped breathing. After being stabilized and requiring prolonged ventilator support, her family sought further care and transferred her all the way from Ipoh to Sunway Medical Center, Sunway City, for support. At sunmed, a multidisciplinary team came together to uncover the underlying cause behind her repeated difficulties in breathing independently. Through coordinated care involving our MDT as shared by Prof. Gan, she was able to overcome this challenging journey and continue her recovery. This is her story, a second chance.
Yang tak sedar tu saya dah dalam kepala saya anak saya dah meninggal. Macam tak percayalah boleh berlaku dekat anak saya macam tu. Nama saya Siti Nurhayati binti Hasai. Saya dilahirkan pramatang usia 35 minggu. Saya kena bersalin awal disebabkan preeklamsia. Masa tu saya nak cuba nak bagi susu dekat kelab tu, tiba-tiba dia lembik atas badan saya. Saya pun dengan paniknya, saya tengok kenapa ni kan. Saya cuba letak baby ke atas katil, saya cuba tekan dada dia, saya cuba buat CPR. Lepas saya tengok satu kali lagi, dada dia macam naik, so dia bernafas. So saya call jiran saya, minta tolong bawa ke emergency. Anak saya 7 kali intubated. Yang terakhir tu, doktor cakap lah, kena bincang untuk tracheostomy. So masa tu saya rasa berat hati, saya rasa macam saya nak cuba second opinion. Saya ada bincang dengan doktor tu, dia ada cakap lah, Sunway Medical ada PICU. Anak saya boleh ke sana lah. Sebelum dia accept anak saya ni, doktor sini cakap anak saya mungkin ada kaitan dengan jantung. Saya dah dapat satu harapan untuk anak saya untuk elakkan daripada tracheostomy tu.
So when I received this case, parents have followed the suggestion, go for tracheotomy, meaning we will not find a true answer of the problem, and the heart will continue to cause problem, and lung will also fail, and she may or may not survive. If survive, also with a complication, and her life will be shorter. So I look at the evidence, and I could see the heart seemed to be a main problem in the whole situation. My plan is to get my cardiologist, Dr. Ang, to come in to do another assessment, see whether the thing heart has any problem which is not controlled, and to see I can give a second chance for Kyla.
So from my scan, I found that the child actually has a big hole in the heart, and both of the lesion causing the baby went into heart failure.
Saya terkejut lah. Dia cakap lubang tu sangat besar dan perlu buat pembedahan. Macam tak percaya lah boleh berlaku dekat anak saya macam tu.
And because of that, that leads to the flooding of the lung, and that make the patient cannot breathe on his own and thus need ventilation.
Upon review, I noticed that Kailash has a heart defect since she was born, and this is causing her to have problem in her breathing. Further management was being taken in Sunway.
So with this information, in a layman's term, you drown the lung, and the big vessels to the heart were compressed, and because of this, it is not easy to extubate.
Because we have different subspecialty, that's why we call multidisciplinary team. We support each other. We have a very good support from ICU as well. Together, to have a discussion, decide on the best option for the patient.
With that kind of decision, we propose it to parents. They also agree with the proposal to go for surgery rather than go for trial extubation. Kaila returned from operation theatre. Kaila came back, situation wasn't that great initially because the heart, after the bypass, the heart function wasn't that great, and we require to put medications for the heart. Fortunately, with support, with medication, breathing support from the machine, after the next day, that the heart showed us significant improvement. Quite a big relief, and the heart started to become better. We know that Kaila is going to improve with time. We start to see hope is now more evidence, and her weight is far away for her to catch up. Once you have this heart condition, you cannot provide them with too much of volume. So we have to make this nutrition in a more concentrated form. Dr. Shirley is our dietitian, so she'll be helping us in doing this. By doing so, we see that Kaila is able to accept the nutrition, the feeding, and she's gaining weight with time. And good news is parents told us that she's more hungry than before. She wants more, and that is one of the most beautiful news that we want to hear from parents.
Memang saya sangat bersyukur sangatlah kira boleh balik rumah terus sihat, dapat jumpa kakak-kakaknya. Memang saya sangat berterima kasih lah dengan rawatan di Sunway Medical. Terima kasih juga kepada Dr. Gan, Dr. Ang, Dr. Nazila, semua terlibat nurse di ICU yang banyak jaga anak saya. Terima kasih semua yang selamatkan anak saya. Tim yang hebat.
Okay, because short of time, is there any question from the floor? Maybe we allow one or two questions from floor first. If none, then I ask a question from the virtual side, one of the participants. First question is, in ASD-associated arrhythmia, like atrial fibrillation, will it go away after we closing the defect? Maybe Dr. Lim want to ask.
Thank you. The first thing that we need to know is that how old is the patient? Because ASD itself, yes, it causes volume overload and especially right atrial dilatation. Has the patient had atrial fibrillation prior to that? Because we have chronic dilatation that will cause arrhythmia. If you have already had scarring in the atrium, closing the ASD itself, even though it reduces the RA-RE volume overload, it does not take away the arrhythmia component. So a component of age is very important. Scarring is very important. So if you close the ASD of a 5-year-old versus a 70-year-old gentleman or lady, is much, much different. So we need to know whether component is there prior and then age. So there's no guarantee. But if there's still arrhythmia, we still deal with it. We still need to put a medication. And if let's say it is something that we can amenable through electrophysiology study or ablation, then obviously we will do it before we close the ASD. Thank you.
Okay, so for the second question, this one for the surgeon, Dr. Ahmad. So the participant asked, for TOF repair, are all cases need transannular patch or alveolar reconstruction?
Thank you for the question. No, not all patients require transannular patch. In fact, we try as much as possible to preserve the pulmonary valve and the pulmonary annulus. The reason is to eliminate the or prevent the pulmonary regurgitation from occurring, and then having the right ventricle dilate and making the patient require second intervention in their later life. So, and that's the other reason why we also delay the operation until they're about 4 to 5 months, 4 to 6 months, because if you operate on them earlier, there is a higher chance of requiring a transannular incision. So in principle, what we try to do is to preserve the pulmonary valve and primary annulus, but obviously not all patients are amenable to preservation. Some patients present with very small, very hypoplastic pulmonary annulus. In those situations, we cannot preserve their own annulus and valve, so we will have to subject them to transannular patch. And the number is decreasing these days. We are preserving a lot of annulus and valve to maintain that principle to retain their pulmonary valve competence. And additionally, nowadays, since the beginning of last year, we have added an additional armamentarium to our practice, where in patients who are more than 2 years of age, we can actually use their pulmonary and their right atrial appendage. We can turn them into a bicuspid pulmonary valve. So if these patients require a transannular patch, we can actually place in a valve that is created from their own parts of their heart that has the potential to grow with the patient. It's still early. We have about 50 to 60 patients now on our watch, and we hope that these patients will have their valve growing as they do, and that eventually they will not need pulmonary valve replacement or pulmonary valve implantation as described by Dr. Lim. But that we need time to know this, and also that if we have to do a transannular patch in this group of patients, it would not stop us from doing it, because we have something that we can offer to the patients to prevent them from developing pulmonary regurgitation.
So the third question also for Dato. The third question also for Dato. The virtual participant asks, for ASD and VSD surgical closure, with the surgery cause any electrophysiological problem, such as bundle branch block and so on?
They are separate conditions. The atrial septal defect are almost free of any electrophysiological complications. For the ventricular septal defect, there is a less than 1% chance of complete heart block. Those patients, and in that 1% also, there is less than 0.5% of them will require a permanent pacemaker. So they may develop some electrophysiological abnormality, either a bundle branch block or quite common a junctional ectopic tachycardia in their early postoperative period. But these are usually transient and they recover. But about 0.5% of these patients develop complete heart block that will require them to have a permanent pacemaker implanted. And usually that's done within the 7 to 10 days after surgery. It's very, very uncommon. We don't have it here in this country, but in the West, they actually have measures to actually detect or predict where the bundle is around the area of the VSD. They have devices that can tell them approximately where the bundle is, and then during the implantation of the patch, they can actually avoid damaging. Again, this is still something that is advancing. It is not available elsewhere, but just to point out the problem that you are trying to talk about in that question is that this procedure has complications, but we are trying our best to minimize the complications. And I can confidently say that the risk of heart block is actually very, very low with our understanding of the anatomy of the conduction bundle in the hearts.
Okay. So another question from the participant, but I'm not sure why lah. He said during neonatal screening echo, so depend on the indication, but he said during neonatal screening echo, for an asymptomatic baby with no heart murmur and found to have PDA, PFO, mild TR, how should we follow up the patient?
Okay, Dr. Ang. It's a very interesting question because number one, why would someone do a neonatal screening echo when the patient is asymptomatic? But let's say it was done for whatever reason. Having a PDA itself is already a problem. So we need to monitor the PDA, whether it is no murmur or asymptomatic, because a PDA that is asymptomatic may be symptomatic as the child grows up. Or when the patient has a PDA, develops a fever, you may be surprised. Infective endocarditis can sit in the PDA. Yes, I've seen PDAs having IEs. So this patient had to be subjected to six weeks of antibiotics and subsequently close of the PDA. So PFO itself is a bit iffy because sometimes when the baby is small, you can't really see the septum or you can't really see the PFO well. So we need to follow up. If the patient has a PDA, obviously you need to follow up the patient. So we will give them an interval where we can see in maybe first time we pay in neonatal visits, then we'll see them in 1 month's time. If patient is well, maybe in 2 months or 4 months. But depends solely on how the patient is. Okay? Dr. Ang, any input from your side?
I think you answered very well already.
One more thing to add to Datuk just now. So when the patient comes back from any TOF repair, the first thing our intensivists will do, put in the ECG, make sure no heart block. And they will they will actually print out an ECG for us to report, make sure there's no cardiac rhythm issue. So it's quite important. And I think we work as a team and everything is like a clockwork now. So the nurses know their part, intensivists their part, the pediatric cardiologist will be pushing in the machine, shooing everyone away. So in a way, it's a very busy, but it's organized chaos, I would say.
Okay. Any question from the floor?
My question is, AST and VST already a congenital disease, but I want to ask the TOF. What is the ideal age for repairing surgery of the TOF? And how much the cost? Surgery, tracheology or fault?
You asking about the timing of surgery?
Yeah?
The question is about timing of surgery for TOF.
Yes. And age, ideal age repairing for surgery.
The ideal age is around
Yes.
3 to 6 months. On average, from our experience, is around 4.5 months, and at a weight of about 3.5 to 5 kilograms. That is the best time for them to have the surgery. It gives the lowest mortality and the best outcome. But some patients present very early in life as a neonate, and they are cyanosed and their saturation is low. They would require something to be done. Most of the time, we know from experience that the surgery in the neonatal period or even early infancy, the mortality is very high. So in those situations, we avoid doing the total correction. So what we do nowadays with interventional cardiology, first of all, if there is a PDA, usually we can sustain the PDA with prostaglandin, and that will maintain their saturation until they are out of their neonatal period. If the PDA doesn't last, then if there is a PDA, then we can stent the PDA. Dr. Lim, Dr. Ang, they can stent the PDA and maintain the patient with good saturations until they are 3 to 6 months of age. If they don't have a PDA, you've heard about RVOT stenting. We can stent the RVOT if the RVOT anatomy is suitable for stenting. And then again, the patient can avoid having surgery in this early period where the mortality is high, and they can be sustained with normal saturations until they are 3 to 6 months of age. If they're not suitable if they don't have a PDA and the RVOT is not suitable, then we do the biologic Thomas shunt, which is a shunt from the systemic vessel to the pulmonary artery to maintain the saturation again until they are about 3 to 6 months of age. So if you can have that as planned when you diagnose them early in life. But there are patients who present later. They may present before schooling. So those patients, you need to operate them immediately. Then there are still these days patients who present when they are warga emas like me, unfortunately. So those patients also, we need to then consider other things as well, whether it's beneficial to do something for them. So those is the spectrum of the disease, right from birth until they are warga emas.
I think to echo what Dato' Seh mentioned, as we progress nowadays, we have antenatal scans, and our ONG colleagues actually do good antenatal scans, and we actually can preclude to them the antenatal diagnosis. And when mother is actually concerned, they actually look and see us pediatric cardiology, and we can counsel them what's the plan forward. And when the baby is born, the first thing we do is make sure to confirm the echo diagnosis, and then from there we plan. And depending on how the patient is, as Dato' mentioned just now, we will either stand the PDA. The PDA is not the saturation is not maintainable. We can, prostaglandin is first, stand the PDA, and even RVOT, balloon and stenting. And obviously, if none of these are available or cannot be done, then obviously we get a surgeon in to put in the BTT shunt. If the age is too small, the child is too small, we can't, because it's highly risky. So we will buy the baby sometime, grow the baby, then we go in for definitive repair. Yep, that's all.
Thank you so much.
Any other question?
Keyword is early referral, early diagnosis.
I think one of the participants, virtual one, asked, is lung transplant available in Malaysia?
Actually, that is a very, very good question. We just did the first heart lung transplant a week ago. That was the first in Malaysia. That's for someone with Eisenmenger syndrome. This is the patient who has left to right shunt that has been neglected and developed pulmonary hypertension, and eventually require both the replacement of the heart and the lungs. It was a success.
So the question actually early on is more complicated. It says it's a patient with post-Fontan with necrotizing pneumonia. So it's asking how to manage. I think if the lung transplant is available and it post-Fontan, maybe we wait for the heart and lung both fail, then heart-lung transplant is better than just lung transplant. Is it? Yeah. Okay. So because of short of time, we had to close the session. Thank you.
Okay, thank you everyone, and thank you to our panelists for the insightful discussion and for sharing your perspectives on baby Kaila's journey. This case truly highlights the importance of multidisciplinary collaboration, managing complex pediatric conditions, and the impact of a coordinated approach in improving outcomes for our young patients. With that, we conclude our panel discussion, and thank you again. At this time, it is my pleasure to invite Dr. Loh Kwai Siong, Medical Director of Sunway Medical Center, Sunway City, to deliver his opening remarks. Please join me in welcoming Dr. Loh to stage.
A very fruitful and insightful discussion just now. So, okay, respected speakers, distinguished guests and participants, ladies and gentlemen, good morning. On behalf of Sunway Medical Center, Sunway City, it is my pleasure to welcome all of you to the 4th sunmed International Pediatric Symposium. I'm proud to see how a platform originally created to share knowledge has grown into an international meeting of minds. This year, we are honored to welcome speakers and delegates from various countries, showing our shared commitment to advancing pediatric care without borders. Our theme this year, Pediatrics Without Borders, integrating subspecialties for complex pediatric care, reflects the dynamic evolution of children's healthcare. We are privileged to learn from experts across leading international institutions, including Apollo Children's Hospital in India, Rama Tibodi Hospital, Prince of Songkla University in Thailand, together with our distinguished speakers from Sunway University, Sunway Medical Center Damansara, Sunway Medical Center Velocity, and our own esteemed distinguished pediatric specialists. Caring for children with complex conditions requires seamless collaboration across multiple disciplines, combining expertise to deliver the highest standard of care. For instance, the management of a complex pediatric liver tumor relies on the expertise of multiple disciplines, such as pediatric surgery, radiology, anesthesia, pathology, oncology, and also transplant surgery. This collaborative approach will be highlighted in detail in one of the key sessions tomorrow. At sunmed, we also embrace this multidisciplinary approach. This exact commitment to integrated care is at the heart of our mission. Over the years, our pediatrics services have grown to 28 subspecialties under one roof, delivering comprehensive and end-to-end care for children across a wide range of medical and surgical needs, including the most complex cases. Proud to share also that Sunway Medical Center now is officially a member of the St. Jude Global Alliance, a meaningful milestone for our pediatric hemato-oncology and BMT team. This is also an important step forward in strengthening our pediatric cancer care through global collaboration, learning, and also shared expertise. Special thanks to Dr. Yap Sao Yi for making this possible, and also grateful to our entire team for the achievement. As we continue to advance our services, we look forward to the opening of Tower F, our dedicated children's tower. This further marks our commitment to provide the purpose-built, compassionate, and also technologically advanced care to better serve the children and also their families. Ultimately, today's symposium is also an opportunity to connect, exchange ideas, and also advance pediatric care together. Before I end my speech, on behalf of the hospital, I would like to express my appreciation to our speakers, moderators, organizing committees, sponsors, and also to our participants. Your support and presence today make this symposium possible. Thank you, and I wish you all a successful symposium.
Okay, thank you, Dr. Loh, for remaining on stage. And would like to invite all our distinguished guests, our speakers, our moderators, and our VIPs up to stage for a group photo session.
Every time you pass me by, something wakes I cannot
Dr. Cham.
quiet fire beneath my skin.
Okay, just up this way.
Like a song that won't give in. I keep your name behind my smile, holding on for just a while. This secret love lives in the blue, in every breath that leads to you. Soft and deep, though never shown, my heart has made your soul its home. In the glance becomes a spark, lighting corners of the dark. What I never say out loud still is strong and still is proud. This secret love lives in the blue, in every breath that leads to you. Soft and deep, though never shown, my heart has made your soul its home. Maybe one day you will see all the love inside of me.
Okay, thank you all our speakers, our delegates, and our moderators. Would greatly appreciate if all our delegates, speakers, and moderators could kindly have a seat. We will now capture a group photo with all our participants here today. Kindly remain seated so our camera and photography team can take a photo. Thank you. Okay, my apologies. We would actually now like to kindly invite all the speakers, participants, moderators, and distinguished guests to proceed with lunch outside. So we have a buffet table outside and also some booths and exhibitions for you to peruse in the free time. Please note that our lunch symposium will commence shortly by Dr. Muhammad Azri Zainal Abidin on Malaysian allergy prevention. Until then, enjoy your break. Thank you. Actually, do you have WhatsApp? Maybe I can just this one, right?
Every emotion felt like danger, felt like death. I could feel the air grow warm as your shadow touched my form. Softest reaction. Hold me closer, hold me slow. There's a fire already words can show. Every second lingers near, like the night itself is here. In this hush I lose control. With your rhythm in my soul. Attraction. Softest reaction. Pull me closer, hold me slow. There's a fire. I stood at every door. Through the noise and through the rain, I would find your heart again. Not by chance and not by fear, but because you feel like home so near. I choose you again, my love. Like the moon returns above, through the dark and through the blue, I'd still find my way to you.
Okay.
Good. Okay, Assalamualaikum and good to invited by Sanwi. I'm also input my on the impact. Guideline take for to go section. Say uh, develop point on public well society as a trouble uh, with changes. Disease has been dramatically. So back in the 90s, if you look at asthma, about 20 million cases, it's risen to 2,000 to 262.4 increase. So I'm sure every as that are being because the increase. Same thing that we're a topic type. So it's all 7% increase, right? This shows that is and dietary transition. So we're actually a more Western dietary food. So Malaysia is actually heading towards that. So we are going to see, or we are seeing increase in countries. Cases, especially asthma, right? But issue diseases, it can aspect, you know, old, old, yeah, it, how to moderate, but I, but I answer it helps parents or careful with food allergy because sometimes parents will, so be careful, right? With the that's allergy, so be careful. It's high numbers, even conservative numbers. The numbers are actually becoming more, right? So you can see about 60% of allergies appear in the first year of life. So I tend to use this, the allergic march. If a patient comes up to me and then says, oh, my baby has food allergy or eczema early on in infancy, I will tell them, just be careful that your child is at risk to later develop respiratory allergies, right? Asthma comes after that when they're in the kindies, and then look out for rhinitis when they reach their school or preschool period, right? So you can predictably see this. So about 30 to 40%, 30 to 50% that has initial food allergies, they tend to develop the atopic dermatitis, followed by the asthma, and then the allergic rhinitis, right? But of course, not all cases will present like this, right? So this is basically a population-based number, right? For individual, of course, there are individual variations, right? So allergy impacts all layers of society. So for the infant and child, of course, you've got effect on your quality of life. So it impacts their sleep. With atopic dermatitis, you see that they've got sleep disruption, their functional limitation, and of course, when they're cranky, there's also emotional impact. All right, so it may impact their future health as well. So for the family, it affects the quality of life, and also it increases their financial burden. So imagine having a child with certain cases of Okay, so pardon the technical disruptions. And of course, for society, there's real financial burdens. All right, so imagine if you have a child with eczema, you're actually going to increase your output or expenditure on the skincare. So it's been estimated at around 1,000 to 3,000 ringgit per year for that family. If you've got someone with asthma, the out-of-pocket expenditure can go up to 2,000 to 5,000, inclusive of if they require acute admissions or acute visits to the ED or the GP, right? So this is important. When you have early allergy risk screening, which I'll tell you after this, then we can implement intervention or prevention strategies and then subsequently reduce. So by reducing, then you're also reducing the overall health as well as economic burden to the population, right? So for allergy prevention, it starts with identifying those who are at risk. So currently, a good measure is actually having a good family history of, you get the family history of allergies. Maybe in the future, we can implement biological markers as well as asthma, as well as allergy genes. But this is going to be costly and it's going to burden the health economics, all right? So identify, then we can start implement whether you need to manipulate the environment and then implement primary as well as secondary preventions, right? So for the family history of allergies, yes, ask whether the sibling or the parent has any atopic dermatitis, allergic rhinitis, asthma, as well as include food allergies for family history, right? So this is the numbers. So even if you do not have a parent or a sibling with allergies, the risk of allergy in that child or offspring could be about 10 to 20%, even without any parent or sibling, right? It goes up once you have a parent with some form of allergies, it goes to 20 to 40% medium. And then if you have a sibling, same 20 to 40%. So the risk increases to 50 to 80% for the offspring if you've got one parent, one sibling, or both parents have some sort of allergy. So these numbers you can tell the parents, right? But actually, 50% of allergic children, they may not have any family history at all, yeah? So keep that in mind. So family history is actually a very efficient tool. You don't have to rely on skin prick tests, which can be costly. Not everyone has access to skin prick testing. It's very simple, low cost, and very easy to integrate in every day-to-day practice, right? So early prevention strategies are key. So early on, you would want to modulate the immune system early, because the first 1,000 days, there's immunoplasticity, right? So you can induce tolerance in high-risk patients. You can actually then implement moderate dietary as well as environmental exposures. Subsequently, once you start preventing, they have less symptoms, then you reduce the financial and disease burden, right? And finally, you impact the broader population. So less unwell children. So you're not just preventing, you're actually increasing tolerance for everyone. Okay, so the objectives of the MEP guideline is basically providing evidence-based recommendation for preventing allergic diseases, especially those at-risk infants. So we mentioned the ones before that you have family history of allergy. So then you identify those who are at risk, and then by implementing this, we are trying to promote overall maternal as well as infant well-being, right? So you can see in the MAP guideline that you have at hand or on the table, these are the table of contents. So I'll be covering from section 2 only till section 5, right? For the section 6, environmental as well as secondary allergy prevention, I think it's a lot to cover for just a 20-minute talk. So I'll soldier on with the subsequent sections, right? So for the core recommendation for primary prevention, maternal and dietary behavior, right? Remember, this is all to prevent allergic disease or allergic conditions in the offspring. So first recommendation, do not, for the maternal avoidance, do not, right? There's no more of this advice that mothers should avoid allergenic foods during pregnancy or lactation, right? So we have moved away from the previous classical teaching that when you're pregnant or lactating, don't take any allergenic foods, right? But if the mother is allergic to the food, please do continue to avoid. Don't want them to suddenly have anaphylaxis and go to emergency department, all right? Just remember, if the mom is already allergic to the food, do not advise them to take that because Dr. Azri said so, all right? So don't avoid allergenic foods if you're not allergic to, all right? So this has positive outcomes for the infants, right? So increases their tolerance, and you actually then prevent allergies in their offspring, right? So again, maternal avoidance of inhalant allergens, right, during pregnancy or lactation is not recommended. So they have, the old advice was before this for maternal moms who are pregnant, right? So remove the cat from the house. Remove the dog from the house. That was the old advice. Actually, you do not advise that anymore. You should not. So even the dust mite avoidance, of course, you want to keep your home clean. That one we still advise, but no extra measures, right? So it actually improves or reduces allergic diseases in the offspring. Actually, having the pets at home actually improves. Yeah. So probiotic supplementation, this is quite a controversial one, but the panel has moved on ahead. So during prenatal and postnatal period, so it does demonstrate some potential benefits. So it's promising, it's a promising area. So if you are asking which strains of probiotics that has been studied a lot, so the LGG, lactorhamnosus GG is one, lactorhamnosus HN001 is another one. So the Bifidobacterium breve M16 is another one that's quite well studied. So those are the positives, right? So for the maternal supplementation of fish oils and vitamins, we don't say recommended, but as yet there's a lot of data say yes and no. So we're actually going in between. We don't put any specific recommendations, right? So it's still insufficient, right? And the final one for maternal diet behavior recommendation, keep the moms happy, right? Do not stress them out. So this is a very good advice for the husbands, right? So maternal stress levels actually it does affect offspring outcome, right? We do see more infantile wheezes in mothers who are stressed prenatally, right? So yes, maternal health, maternal mental health is of utmost importance, right? So cesarean section should remain a clinical decision. You don't simply just do a C-section just for allergy prevention. Of course, it's very obvious to say that, right? Oops. So for breastfeeding, I have to say first and foremost, we're just at the end of the breastfeeding week, if everyone knows, right? So still, as a pediatrician, we will die recommend this, right? Breastfeeding is first, minimum 6 months, right? It's always part of the pediatric code. We will recommend breastfeeding, right? So exclusive breastfeeding, yes, we recommend. Very, very, very important, not just from allergy prevention, but for nutritional purposes and growth, as well as development. So during breastfeeding, maternal avoidance of allergenic foods is not recommended, right? So actually, if they do consume, again, say, mom eat the allergenic food, they view, right? They get unwell, so we don't. So if they should not avoid allergenic foods, because actually small amounts of the allergens actually go into the breast milk and enters the baby's GI system, and it actually promotes oral tolerance, right? So do not, right? Unless, of course, then the baby has some non-mediated food allergy, they start having bloody stools, right? So that's another indication, okay? So for infant formula recommendation, so remember I start with, yes, everyone must breastfeed, right? In the event that the baby wants introduce a cow protein formula, cow milk formula, then transition back to exclusive breastfeeding. Do say this, we do recommend they still get regular exposures. So most people will ask how much, how frequent. And so I'll just have to go back to the Okinawa study by Sakihara state trial. They gave 1 tablespoon 10 every day of cow protein just to maintain tolerance, that they don't develop cosmic protein later on, right? Okay, so again, for babies who are not able to be exclusively breastfed for any reason, right? So in this case, if they're not able to be, we do still put the recommendation that the partially hydrolyzed formula is recommended for prevention starting at 4 to 6 months. They're not being able to breastfeed. Okay, so this is for at-risk infants. Okay, soy, amino acid, goat's milk formula not supported for prevention, allergy prevention. Something that you can say to parents, babies are already having cow's milk protein allergy, don't give goat's formula. 90% similarity, right? So there's just keep that in mind as well, right? So prebiotic supplementation put as a maybe, right? HMOs may be considered for allergy, right? So if you want to know which specific one, you can meet me after this, right? Complementary foods should be introduced. This is based on the LEAP trial. So they introduced peanuts very early on to 4 to 6 months babies, and they noted that actually peanut allergies very much less in those who were introduced early. So we still go, of course, the WHO will say 6 months is the age, but once you're able to have net control, and you may want to start, right? So steps you notice for complementary food introduction recommendation. So number 1, you introduce allergen foods after the complementary foods have been started. Then they introduce the initial taste, introduce small quantities, quarter teaspoon, then you up the dosing. Once you start using the allergenic foods, in this case is some cow's milk, some dairy, sesame, egg, right? So 3 to 5 days if you're trying to introduce, right? So for eggs, don't give them raw eggs, it's dangerous. Half cook, maybe not so good. The more you cook, the more protein changes, especially the ovalbumin. So boiled egg would be a good option, right? So once they're introduced, they should regularly consume the allergenic foods to, again, maintain tolerance, right? So again, I'm at the end. It's a tool to for you all to use, right? So again, we're clinicians, we apply clinical judgment, and every individual patient, of course, needs to be tailored for their condition, right? Guidance and age, right? So again, I hope that by disseminating this information, that everyone gains some knowledge and information, and then I think it's everyone's responsibility that we combat the rise in diseases in the society, right? So again, first and foremost, we try to identify who are at risk, and then we can start implementing the measures for prevention, right? Thank you very much.
Okay, thank you very much, Dr. Azri, for that insightful presentation and for sharing your valuable expertise on Malaysian allergy prevention. We truly appreciate your time and contribution to today's symposium. Ladies and gentlemen, you may now take this opportunity to continue your networking, visit the exhibition booths outside, or continue your conversations over lunch. We kindly invite everyone to be back in the hall by 1:10 for our next symposium. Thank you, and we look forward to welcoming you back shortly.
Concerned about your child's growth? Give them Ascenda. Now with Growth Plus Advantage. High in energy, protein, and 100% of key nutrients for increased height and weight in as early as 3 weeks. Boost your child's growth with the new Ascenda.
At Sunway Medical Center, we believe that safeguarding their health is how we protect and harness that future. Whether facing a scheduled surgery or an unexpected emergency, we are here to provide the highest level of care and support. From the moment your child arrives, our commitment is to provide immediate, top-notch care because we understand how precious every child's life is. We are equipped to handle any crisis with 24 subspecialties. Every second counts when your child's health is at risk. Our team acts swiftly and effectively, ensuring comprehensive care for every pediatric emergency and surgery.
Our compassionate medical team supports your child every step of the way. Thanks to the latest digitalized and cutting-edge equipment, we ensure precise and efficient diagnostics.
In our pediatric intensive care unit, continuous monitoring and advanced technology are essential. Our state-of-the-art digitalized technology helps us deliver seamless, all-the-time monitoring, allowing us to provide extra attentive and compassionate care to our young patients. Comfort during critical care is our priority. Our PQ is designed to be a friendly, supportive environment that helps children feel more at ease.
A safe environment is crucial for recovery. We provide thyroid care with a protocol-guided early warning score system, and our VIP rooms offer a serene and cheerful setting for both mental and physical recovery. Supported by attentive care, from our dedicated nurses.
Watching our young patients recover and return to their playful selves is the greatest reward. At Sunway Medical Center, we believe in nurturing the next generation. Our dedication to pediatric healthcare ensures that our children can grow up healthy and strong. Our children are our future. By protecting their health today, we ensure a brighter tomorrow.
When you hear the words heart condition, it can feel overwhelming, especially when it involves someone you love. But today, even the most complex heart conditions can be treated, managed, and in many cases, successfully overcome. I'm Datuk Dr. Ahmad. For over 30 years, I've dedicated my life to treating heart conditions present from birth in babies, children, and teenagers. And in that time, I've performed more than 5,000 surgeries across 4 countries. I also led volunteer missions for underserved communities. But for me, it's never just about numbers. Every case reminds me of the trust patients place in my care. Congenital heart conditions mean the heart didn't develop in the usual way. Some children are born with a hole in the heart or born as blue babies, while others have valves or blood vessels that don't function as they should. Some conditions are detected early, others only become clear later in life. But without proper care, they can lead to serious complications over time. Every patient is different. Some may only need monitoring and medication. Others may require surgery to repair or reconstruct the heart. Where possible, I use minimally invasive techniques, allowing for smaller incisions, less pain, and faster recovery. But heart care is never done alone. At Sunway Medical Center, Sunway City, I work closely with a dedicated team of specialists, nurses, and support staff, ensuring every patient is cared for at every stage, from diagnosis to recovery. At the heart of my care is communication. I always take the time to explain each condition clearly and simply, so you and your family feel informed and confident moving forward. Whether you are parents seeking answers or someone facing a heart condition, you are not alone. And with the right care at the right time, many patients are able to heal, recover, and live life more fully again. At Sunway Medical Center, Sunway City, this is what we strive for every single day.
Concerned about your child's growth? Give them Ascenda, now with Growth Plus Advantage. High in energy, protein, and 100% of key nutrients for increased height and weight in as early as 3 weeks. Boost your child's growth with the new Ascenda.
Our children are our future. At Sunway Medical Center, we believe that safeguarding their health is how we protect and harness that future. Whether facing a scheduled surgery or an unexpected emergency, we are here to provide the highest level of care and support. From the moment your child arrives, our commitment is to provide immediate, top-notch care because we understand how precious every child's life is. We are equipped to handle any crisis with 24 subspecialties. Every second counts when your child's health is at risk. Our team acts swiftly and effectively, ensuring comprehensive care for every pediatric emergency and surgery.
Our compassionate medical team supports your child every step of the way. Thanks to the latest digitalized and cutting-edge equipment, we ensure precise and efficient diagnostics.
In our pediatric intensive care unit, continuous monitoring and advanced technology are essential. Our state-of-the-art digitalized technology helps us deliver seamless, all-the-time monitoring, allowing us to provide extra attentive and compassionate care to our young patients. Comfort during critical care is our priority. Our PQ is designed to be a friendly, supportive environment that helps children feel more at ease.
A safe environment is crucial for recovery. We provide tailored care with a protocol-guided early warning score system. And our VIP rooms offer a serene and cheerful setting for both mental and physical recovery. Supported by attentive care from our dedicated nurses.
Watching our young patients recover and return to their playful selves is the greatest reward. At Sunway Medical Center, we believe in nurturing the next generation. Our dedication to pediatric healthcare ensures that our children can grow up healthy and strong. Our children are our future. By protecting their health today, we ensure a brighter tomorrow.
When you hear the words heart condition, it can feel overwhelming, especially when it involves someone you love. But today, even the most complex heart conditions can be treated, managed, and in many cases, successfully overcome. I'm Datuk Dr. Ahmad. For over 30 years, I've dedicated my life to treating heart conditions present from birth in babies, children, and teenagers. And in that time, I've performed more than 5,000 surgeries across 4 countries. I also led volunteer missions for underserved communities. But for me, it's never just about numbers. Every case reminds me of the trust patients place in my care. Congenital heart conditions mean the heart didn't develop in the usual way. Some children are born with a hole in the heart or born as blue babies, while others have valves or blood vessels that don't function as they should. Some conditions are detected early, others only become clear later in life. But without proper care, they can lead to serious complications over time. Every patient is different. Some may only need monitoring and medication. Others may require surgery to repair or reconstruct the heart. Where possible, I use minimally invasive techniques, allowing for smaller incisions, less pain, and faster recovery. But heart care is never done alone. At Sunway Medical Center, Sunway City, I work closely with a dedicated team of specialists, nurses, and support staff, ensuring every patient is cared for at every stage, from diagnosis to recovery. At the heart of my care is communication. I always take the time to explain each condition clearly and simply, so you and your family feel informed and confident moving forward. Whether you are parents seeking answers or someone facing a heart condition, you are not alone. And with the right care at the right time, many patients are able to heal, recover, and live life more fully again. At Sunway Medical Center, Sunway City, this is what we strive for every single day.
Concerned about your child's growth? Give them Ascenda, now with Growth Plus Advantage. High in energy, protein, and 100% of key nutrients for increased height and weight in as early as 3 weeks. Boost your child's growth with the new Ascenda.
I hope everyone has enjoyed your lunch. We are now moving on to our next symposium session, Vaccination and Beyond, Advances in Pediatric Immune Protection. Moderating this session is Dr. Tan Tiong Yong, a consultant general pediatrician whose clinical interests include child health, growth, and development. He graduated from the University of Malaya in 1983, and he obtained his membership of the Royal College of Physicians in the United Kingdom in 1988. Before serving in major public hospitals, including Kuala Lumpur General Hospital, he later practiced as a consultant pediatrician at Chinese Maternity Hospital before joining Sunway Medical Center. Having served at Sunway Medical Center since the year 2000, Dr. Tan has dedicated more than 25 years to caring for children and supporting families in this community. Please welcome us in joining Dr. Tan Tiong Yong.
Good afternoon, everyone. Dear colleagues and friends, it's my honor to introduce Dr. Sangeeta Sinaya. She is a consultant pediatrician specializing in pediatric infectious disease and immunology. She obtained her MBBS from Manipal Medical College, Manipal University in 2007, and went on to complete her MRCPH in UK in 2014. Right. Her advanced fellowship training in pediatric infectious disease and immunology took place across Malaysia and India, including institutions such as Hospital Kuala Lumpur, University Putra Malaysia Teaching Hospital, and the Postgraduate Institute of Medical Education and Research in Chandigarh, India. She was also trained in specialized units such as allergy and clinical immunology in the Pediatric Bone Marrow Transplant Unit in University Malaya. Dr. Sangeeta is recognized as the first trained pediatric infectious disease and immunologist in the Ministry of Health Malaysia and was instrumental in establishing the National referral center for clinical immunology services for both pediatric and adult patients. Currently, Dr. Sangeeta serves full-time at Sunway Medical Center, Velocity in Cheras, while also contributing as a visiting immunologist at Hospital Kuala Lumpur. We are privileged today to benefit from her expertise and contribution to pediatric immunology and infectious disease. Please join me in welcome Dr. Sangeeta Sinaya.
Hi, good afternoon, and thank you very much, everyone, for staying, and especially after the wonderful lunch. So don't worry, the topic will be very short, brief, and if you have heard me speak before, it's usually very interactive and very clinical. So I'm very happy and thankful to be here again, and this time I'm not really speaking much on immunology. I'll be speaking more about tuberculosis and early prevention, which is BCG, because my colleagues after this will be also speaking about TB disease. Okay, so I'm not sure how many have read this book. I've just recently obtained it as well. So it actually speaks about how TB is prevalent, okay, and it's a worldwide prevalence. So the author actually speaks to a TB patient in a TB clinic in Sierra Leone. But I think whether we are fortunate or unfortunate, actually TB here is endemic. And I think I've managed TB for more than 15 years or more now. And I think what humbles me is always that no TB disease is the same. So two patients having TB will never be the same. Especially in children, it actually gets harder, and the disease actually it requires a lot of fine-tuning, a lot of investigations, and very subtle signs that you may miss, especially in a child. So that's what we're going to go through today. So this was a few statistics taken this year. So I don't know whether you've heard or seen in the news. This year in 2026, actually we had a few clusters of TB involving adults. But because the adults were, having TB disease, the children automatically came for screening. So I would say even in a private setting, because not many doctors actually manage TB in private, I did receive a lot of referrals. And not just for TB prevention, so not just for latent TB disease. So I have a whole array of patients with pulmonary TB, lymph node TB, lung TB, bone TB. There's so many different types of extrapulmonary TB. So this is a bit of an older infographics. This was somewhere in 2023. So as you can see, even here at this time, there were about 1,500 to 2,000 deaths a year and 6 deaths per average, a day. So I believe these numbers have actually increased because, like I said, I also see TB complications. So when I serve in HKL in the neuroimmunology units or in IPR, I actually help to manage complex cases like the IRIS or immune reconstitution syndrome. So this is something that happens post-TB infections. And we do see that TB has become very complicated because it does involve an immune response, and you have something what is called as like long COVID. You can also have complications like long TB. And this includes inflammation as well. Hence why TB, when you start to see early, you need to intervene and treat it early. Because when you let it grow and you don't intervene at the right time, sometimes it gets harder to treat and manage. So then comes to the topic, why is childhood TB different? I mean, why is it different from adults? What's the difference? So firstly, childhood TB follows these 4 pathways. So you need to have exposure. So definitely it's somebody giving a child TB. So often in clinic, I get asked, doctor, is my child going to give me TB? But actually, it doesn't happen that way. It's usually an adult who has given TB to a child. So the crude numbers are for every 10 for every one child that is infected with TB, that means there are 10 adults walking around with TB. So you can see how these numbers are in a way like in the community. So what happens is after that, they develop latent infection. And latent infection is usually very well contained unless you are immunocompromised or, of course, in children where they are naturally immunocompromised, especially if they are below 5 years old. And then they develop active disease and they can have severe disseminated TB. For example, miliary TB or even TB meningitis, like what they're going to present later. So I think this is also a very important slide. So like what I said earlier, okay, so a child usually has paucibacillary. So paucibacillary means that the bacterial load is very low. In an adult, it is usually a smear positive. So when it is positive, you definitely will spread the TB. And another thing is, in a child, it's usually primary TB infection. However, in an adult, it's usually a form of reactivation. So these are the subtle things that are very important to know because it will also guide your management and your treatment. Okay, so now we come to important part, the first part of the talk today, which is on BCG vaccine. As you know, I think everyone here, except if you are a foreigner, would have received BCG vaccine at birth because it is part of our national immunization program. So basically, it's a live attenuated Mycobacterium bovis vaccine. It is given over the left deltoid universally here. So what it prevents is it does prevent severe disseminated TB. It does prevent things like TB meningitis. But what it does not prevent, and this is very important because, like I said, parents will come and say, doctor, my child has been given BCG vaccine. Why are you still diagnosing TB? So it does not prevent pulmonary TB. It does not prevent the infection of TB, and it does not prevent the transmission. So I think this is also very important. Okay, so before we go to all the abnormal or different types of TB, I think you need to know the normal natural history of how a BCG vaccine heals. So at birth, you have, of course, a normal wheal, which is given, and then later it forms a papule in 2 to 4 weeks, and then it develops into a pustule, okay, and then you have an ulcer formation, a scab, and finally you have a permanent scar. So this is a natural progression. So I want you to remember this slide because we are going to see a few cases and you will see the difference in some of the vaccines. So we'll start with the cases. So this again is a typical scenario. Either it's by the doctors referring or even the parents. So doctor, my BCG isn't healing. So this is a picture. Okay, so they'll say that this is not healing. So go back again to the history. So this is a 2-month-old infant, okay, has got a large ulcer, as you can see here over the arm, and has no fever, very well, growing following the centile charts. And on examination, just one large ulcer, no lymphadenopathy, nothing. Okay, so what is this? Normal, yay, Dr. Shu. So very good. Okay, so this is a normal BCG. So what then do we do? Give antibiotics? No. So obviously we don't give anything. So we have to reassure. Sometimes it involves multiple visits. Sometimes we also have to reassure the doctors. So because they also get a bit nervous, because I don't blame them. Sometimes, you know, they have not seen in a while. So that's why we have a refresher like this, because, you know, it does look scary. So like I said, it can look scary, but most important thing is we just reassure and we tell that it will heal spontaneously. Now, so this is a second case, okay? So pay close attention. Okay, it doesn't look the same as the first one. This one also doesn't look the same, okay? So it's a 6-year-old boy, okay, a traveler, so just a tourist, okay, recently had a BCG vaccination about roughly a month back, okay. So you see a large abscess, which is fluctuant, okay. Here you see delayed healing, but no systemic illness. The child's very well, does not have any systemic signs to suspect any immunodeficiency or other things, okay. So what do you think? Normal or abnormal? Abnormal, very good. So why do you think this is abnormal? Ta-da! Okay, so this is, you will think that this is not common, but it's actually quite common, okay? So this is why this is very important. I think that, as you know, intramuscular, a lot of vaccines are given intramuscular or subcutaneously, but a BCG vaccine is usually given intradermal and through the dermis. So I think a very important thing here is if you give a patient BCG vaccine too deep or intramuscular, it will become like that, what you saw earlier. So that is when you have complications. So definitely a lot of time it takes longer to heal. Okay, there'll be delayed wound healing, there may be a sinus formation. Most of the time we have to involve our Paeds surgical or Paeds orthopedic colleagues because they need to go in and do an IND. But again, so if you are not sure of the technique, please refer to someone who is more confident to do it. Sometimes even in the hospital, we actually ask our NICU nurses to help because they are the ones who do it every day. Okay, so please be careful on this because this can happen. Okay, so this is a third case. So you can see the third case. So this is the picture. Okay, but I'll go through. So this is a 3 months old. Okay, recurrent fever with failure to thrive. So you can see that something is not right. A 3 months old should not be having fever and should be thriving well. Okay, and you can see that there's axillary cervical lymph nodes which are indurated swelling. So you can see the induration in the cervical as well. Okay. The child has a liver and a spleen palpable. So it's also very important to examine the child. And you can see, okay, here you can't really see, but there's a huge BCG ulceration. Okay, so this is a patient of mine who passed away because of disseminated BCG-osis. So this patient had severe combined immunodeficiency. So for those who don't know, I also take care of patients with primary immunodeficiency. Unfortunately, this patient succumbed because the child was given BCG at birth. It's sad because the brother died from at a very early neonatal time and was told subsequent pregnancies should not receive the BCG vaccine. Unfortunately, in a rural area was given, and this child, she stayed on until about 1 year, but we couldn't do her transplant because we couldn't control her BCG infection. So again, like I said, BCG is not without complications. So how do you know when to suspect? So why and when you should think that a BCG complication should be a cause of concern? So firstly, there is systemic manifestations. Okay, like I said earlier, fever, poor weight gain, all those things are not normal. Distant lymph nodes, especially beyond the site. So if it's on the left side, you see on the inguinal, you see on the right side, something is not right. Okay, if there is very big abscess, okay, a liver or a spleen, and of course things like osteomyelitis, if there is seizures, and most important is a family history. So a lot of times if they give you a family history of early neonatal death, these patients must be referred early or just defer the vaccine. If you're not sure, just defer, no harm. You can always give the vaccine later, okay? So, so what are the types of BCG disease in immunodeficiency? So like what we mentioned before is SCID or severe combined immunodeficiency. Some patients with chronic granulomatous disease where they develop abscesses, they may have, or MSMD. So just remember, very important, normally it's a family history. So if there is a family history, please refer early and you can defer the BCG vaccine. Okay, so we are done with the first part, okay, on BCG vaccines. I hope it's clear. So now we go on to latent TB infections in children. So remember, I said one of the most effective ways of prevention and early management of TB is latent TB treatment. Okay, so now first, who should be tested for LTBI? So firstly, household contacts of a smear positive living in a high endemic. So just yesterday, I had a case where, the family, they came all the way from Klang. So they were just informed that the grandfather who lives in the same household just admitted, just positive, but not sure. They said TB only. So they panicked, the whole family panicked. They came because the child's only 3 years old. So, but I didn't know whether it was a smear positive, smear negative. So I actually called up and spoke to the doctors, and it was a smear positive pulmonary TB, okay? So that is why it's very important to figure out and find out the history and what is actually the contact, okay, of the patient, of the index case. And that's why a detailed history is important. So children under 5 years old. So children under 5 have the highest risk to develop severe TB, disseminated TB, hence why they should be tested. And immunocompromised, including those who are on TNF alpha. So for example, like infliximab, okay, and also those post-organ transplantation, chronic kidney disease, or anybody who is on chronic illness, these group of patients should be highly investigated. Okay, so now what are the tests available for LTBI? Again, I want to highlight that despite having all the tests, nothing beats a good clinical history and a clinical assessment, because there are sometimes the test may be negative, but if you still have a suspicion, you should still aim to give them TB preventive therapy. Okay, then you have the MEN2 test or the tuberculin skin test, which is routinely performed. And depending on the age, depending on the immune status, MEN2 of more than 10 is taken as significant. And you also have blood tests like what is known as IGRA or interferon gamma release assays, but this should be not used for children below 2 years old. But so MEN2 and IGRA are basically the same type of screening test. It does not differentiate whether they have a disease or a latent. Even if either one is positive, it just means they are infected with tuberculosis. But you still have to know, where is the TB? Is it in the lung? Is it in the brain? Is it in the lymph nodes? You need to decide. And these tests and these timelines can change. So that's why these group of patients have to be monitored, which we will discuss later. Okay, and of course you can do a chest X-ray as well. So another, just a slide to highlight the difference between LTBI and active TB. So remember, in latent, because they are well, okay, so they have no symptoms. And of course, in active TB, you may have cough, fever. In children, generally, they don't really have that much of night sweats and all, unless they have miliary symptoms. But weight loss, poor appetite, not gaining weight, these are common symptoms in children. Okay, so latent TB, you cannot spread to others, but if it's an active tuberculosis, they can spread. Tests as what were mentioned before, and this I think is also very important. So in latent TB, the immune system is still keeping the germs under control, but in disease, you are unable to contain the TB germs anymore. Okay, so this is based on the CBG 4th edition, okay, the Malaysian LTBI treatment. So there are many options. So out of these options, I think the commonest used are the isoniazid daily for 6 months. Yes, it is given as a directly observed therapy. I do not want a child to be using 2 drugs and getting drug resistance later. So if I'm very sure that they can take or they are able to do that, then I will prescribe. Otherwise, it's safer to just give isoniazid. So this is my preference, but it depends on the clinician treating as well. So, okay, this is a case we're going to discuss. So, a 1-year-old whose household helper was diagnosed as a smear positive TB. Okay, so the helper was sent back home, but the history is the child sleeps with the helper, okay, and the child previously has a few admissions for acute bronchiolitis, still has that occasional cough. A MEN2 done was 15 mm. Okay, so what do we do next? Okay. So, can I have a show of hands? Who will start latent TB treatment? Show of hands? Okay. Can I have a show of hands who will investigate for TB disease? Wow, very good. Okay. All right. Thank you. So, at least, yes. So, we have to investigate. Why we investigate is because the child is not asymptomatic. Okay, the child still has cough, even though previously had acute bronchiolitis, but the child is still having cough. A MEN2 is positive. You need to investigate further. Okay, so a chest X-ray was reported as normal by the radiologist. Okay, I usually get a radiologist to report the X-rays. I don't look at it myself. Okay, a gastric lavage was done, was negative. Okay, we also sent a gene expert for tuberculosis, which was negative. And MTB culture midget. So midget is a fast-growing culture, which can take about 2 weeks, which came back as negative. Okay, so based on this, we counseled. So we started on latent TB treatment, isoniazid for 6 months. Okay, please notify as latent TB. And the most important thing, you need to monitor for 2 years upon completion. So it doesn't matter whether you start treatment or you don't start treatment, the most important thing is monitoring. I do have some patients it can happen. So I think that is a very important take home from this case. Okay, so what are the childhood TB diagnostic challenges? So firstly, they are paucibacillary, so they have a very low bacterial load and they can't expectorate sputum. So a lot of times you need to rely on gastric lavage. And the person doing it is okay, and the symptoms are very non-specific, okay. So the always get the radiologist to reassess, yeah. And of course, wherever you can. So if you're taking a sample, let's say from a limb biopsy, I think are very, very important. They include BCG vaccination, early diagnosis, early diagnosis, and you need to start TB preventive therapy early. I think this is very important. But I've added another one, which I think is also extremely important, is contact tracing, okay? So a lot of times, once they know there is a history, they will just keep quiet. They don't come for contact tracing. This is also where we miss out chance, because giving latent TB treatment can actually reduce the risk of disease progression, and like I said, it can contain. So that's why starting early TPT or your latent TB treatment is extremely important. Okay, so this is at the end of my slide. So just a take-home message, I think BC or unusual complications should warrant a suspicion whether this is something else. Are you missing a primary immunodeficiency? Okay, any child who has exposure to TB should be assessed for latent TB infection. Okay, TB treatment is safe. Okay, safe, and always have, especially for younger children, have a very high suspicion for extrapulmonary TB. There have been times where we've missed TB meningitis, TB gut, so many cases. So please be cautious. Okay, that's all. Thank you.
I think we will keep the question Q&A until the end of the sessions. Let us thank Dr. Sangeeta. Okay, I think the next speaker is Dr. Cham Wing Tang. All right. Dr. Cham is a consultant pediatrician and pediatric rheumatologist at Sunway Medical Center, Bandar Sunway, since 2016. He graduated from University of Malaysia.
About children with rheumatic diseases. Generally, as you know, children with rheumatic diseases, they have immune dysregulation from their underlying disease. They also have increased exposure to healthcare settings because they frequently go into the hospital. They are also on immunosuppressive medications, and as a result of that, they are at higher risk of severe infections. Because of their therapies, they are also at reduced vaccine responses because of their treatment. And yet, vaccination rates remain suboptimal worldwide. I think recently everyone knows about the measles outbreak in America, and is at a very threatening pace because measles is one of the most contagious infections worldwide. So vaccine hesitancy is also on the rise. It remains quite common, unfortunately. And because of this, many children miss opportunities to start the vaccination early. So before they can be started on immunosuppression, they are not vaccinated, so it makes things difficult. So the take-home message is vaccination is an integral part of rheumatology and not just an optional extra. So in general, my patients, you've got patients with lupus, they could have ankle-associated vasculitis, juvenile dermatomyositis, those with systemic arthritis. So they are immunodysfunction because of their current condition, and they are most likely on immunosuppressive medications. And because of this, they are at high risk of pneumococcal diseases, influenza, varicella, human papillomavirus, COVID-19, and other opportunistic infections. Among all these, children with SLE have the highest rate of infection, and they are the greatest risk of mortality because of infection. So, sources of immunosuppression. So first, causes them to be suppressed, and also sometimes their autoimmune disease can enter macrophage activation syndrome, which render them immunosuppressed. Second is they are on biologics. So patients who are on biologics like TNF inhibitors, IL-1 inhibitors, IL-6 inhibitors, abatacept, rituximab, belimumab, and many more are rendered them actually immunosuppressed. Medication-related, compromised individuals are like influenza, which is still at large, RSV, pneumococcus. We have actually vaccine-preventable conditions that should be prevented, like varicella, measles, pertussis, HPV, hepatitis B. And now, so first, there are three important concepts. Safety. When can we safely administer the vaccine? That's a very important thing, because you know they're immunosuppressed, either because of their own disease or due to the medications. So when is the best time to give them? Second thing is immunogenicity. Can they produce antibodies after they're vaccinated? Because if, let's say, they can't produce antibodies and you give them the vaccine, then it's pretty hopeless, getting the inject and then you don't get any protection. And the most important thing is effectiveness. Will it reduce infection severity? So that means if you get the influenza vaccine, will it reduce the severity of the infection, or will you still get the infection and it's still just as bad as the rest? So for example, influenza vaccine may produce lower antibody titers in rituximab-treated patients, but still it significantly reduces the severe influenza. So vaccine categories, there are two, inactivated versus the live vaccines. So in general, inactivated vaccines are considered safe. Things like influenza, pneumococcal, hepatitis B, HPV, COVID, Tdap, HIP, and also IPV. The live vaccines, we have to do it with caution. As you know, the vaccines are still able to generate disease if, let's say, the person is unable to mount an immune response. So things like measles, mumps, rubella, varicella, patient with autoimmune disease. So first is the diagnosis. If you've diagnosed a child with, let's say, for instance, juvenile arthritis, and you'll say, okay, we need to sit down and talk about your vaccine history. So you've got, let's say, for instance, an oligoarticular JIA, just only one joint, just that knee and nothing else. So we said, okay, we're going to probably start you on some NSAIDs, but we probably want to go through your vaccination history because we want to see whether, if just in case your disease progresses and needs stronger immunosuppression, at least I've got a window of opportunity to get you the vaccines first. So if I need heavier immunosuppression, I know you're still okay, right? So we review the vaccine history of the patients. Hopefully they still have the vaccination booklet. Then we do the catch-up vaccines, okay? I think most of us are now starting to introduce the pneumococcal vaccine, the PCV20, because there's availability now. So some of my patients, they have been vaccinated with the PCV13. So I tell them, maybe we should give you one booster, a PCV20, before we proceed with other vaccines. So this is one thing. So you probably also want to offer, if they're not getting the varicella vaccine, to get the varicella vaccines done, and all those before you see whether they require any other things. And then once they are there, the disease progresses, then you need to start immunosuppression. You tell them you cannot have any more vaccines, and you just start immunosuppression. Unfortunately, this is the ideal world. In most of the times, we can't. So we've got a patient with lupus in front of you, with severe lupus nephritis, you have to start immunosuppression. You have no time to talk about vaccine history and everything. But it's good to bear in mind to offer them those inactivated vaccines when we got the opportunity to do so, when the disease burden is much lesser. So many children require urgent treatment because of this. And sometimes, or most of the time, this ideal sequence is not always possible. So vaccination before we start immunosuppression. So whenever possible, get a full MMR. MMR, varicella, hepatitis B, HPV, influenza, if it's able to be done, okay? So if you can't, then this is better because sometimes you want to give all these vaccines first. Before you start, especially the heavier drugs like rituximab, cyclophosphamide, high-dose steroids, or biologics. Live vaccines, ideally 4 weeks before you start immunosuppression. Inactivated vaccines, ideally more than 2 weeks before. So corticosteroids. In low dose of corticosteroids, usually vaccination can proceed normally, no issues. But high dose corticosteroids like those on prednisolone more than 2 milligrams per kilo per day or more than 20 milligrams per day for more than 14 days. So in general, for these patients, live vaccines are generally deferred until at least 1 month after stopping high dose therapy. But inactivated vaccines remain recommended. For methotrexate, most routine vaccines remain safe. Immunogenicity, unfortunately, is slightly reduced. For instance, in influenza, for example, adult data shows that methotrexate withholding for 2 weeks after an influenza vaccination improves responses. But in pediatric evidence, is limited. So for me, in practice, I routinely don't stop the methotrexate just because they're going for influenza vaccine. I just tell them there will be reduced immunogenicity, but there is still protection from severe influenza. And usually most of my patients do still take their influenza vaccine. So normally we don't stop the methotrexate. TNF inhibitors, for instance, like etanercept, adalimumab, infliximab, or golimumab. In general, inactivated vaccines, like I said earlier, it's safe, no issues. Live vaccines, I think it should be avoided because we are worried about potential disease. So, but there is now a growing evidence that in selected patients, with low-level immunosuppression, that means they're just on single monotherapy, they may safely receive MMR booster. But this is case-to-case basis and needs to be discussed with your own rheumatologist. So rituximab remains the biggest challenge because, as you know, it is anti-CD20, it's a B cell, it depletes your B cell. So when it depletes your B cell, it's very good at controlling whatever disease you're trying to control, for instance, lupus. But there is poor antibody formation. And because of this, there is reduced vaccine responses. So responses may remain impaired for up to 6 to 12 months. So we usually try to vaccinate as much as possible before we give rituximab. But this is whenever possible. But if you've got a very sick patient in front of you, you have no choice. If already treated, we usually delay all vaccinations until B-cell recovery is clinically feasible. So usually what I do is, because it depletes the CD20 cells, I will do a CD19, CD20 count to see whether there is improvement of the vaccine, improvement of the cell line, and also sometimes the immunoglobulins. Because after rituximab, there's a drop in immunoglobulin levels too. So when you see there's improvement in the CD19, CD20 cells, you know, okay, the body is back to normal, then you can start doing vaccination. Cyclophosphamide is associated with profound immunosuppression because it affects both T and B cells. It causes lymphopenia. It definitely will impair vaccine responses. So recommendations still stands: complete all vaccines beforehand, whenever possible. Delay elective vaccination until immune recovery. But annual influenza remains recommended. JAK inhibitors, this is a new boy when it comes to rheumatology. It's increasingly used for refractory JIA, interferonopathies, and autoinflammatory diseases. Current recommendations is inactivated vaccines, no issues, it's safe. Live vaccines, generally avoided. So patients on JAK inhibitor, there's growing data to say we should actually start to give them herpes zoster vaccinations becomes actually more relevant among our adolescent population. Currently, the license for the shingles herpes zoster vaccine is for 18 and above, but there are cases where we have to give it younger to protect them because they are increased risk of developing zoster. So disease activity and vaccination. So common parental questions to me is, will vaccination trigger disease flare? As you know, when you vaccinate, your body will produce antibodies. So you say, Alomo, if you're going to produce antibodies, are you going to worsen my child's disease? So the evidence shows that most routine vaccines do not increase disease activity. So that's the good news. Disease flare rates compared between vaccinated and unvaccinated children are the same. So that means even though if you vaccinate or you don't vaccinate, they don't exhibit worsening of their underlying disease. And then vaccination should ideally occur when disease is reasonably controlled. So that means you don't give it when they are highly active. But active disease alone is not a reason to withhold vaccination if the infection risk is very high. Like I mentioned just now, it's like certain cases you have to cover because, let's say for instance, you have an influenza outbreak in your nearby neighborhood, and this child is still on very high immunosuppressive because of his underlying lupus or something like that, we will still vaccinate. Some protection is better than no protection at all. So one vaccine I mentioned earlier is the influenza vaccine. Annual vaccination is recommended for across all cases. Benefits of an influenza vaccine: it reduces hospitalization, reduces ICU admission, and it reduces disease flares triggered by influenza infection. I've got many children actually, after they get an influenza infection, it somehow triggers their autoimmune disease. Either the arthritis gets worse or the lupus gets worse. So by and by, please get the flu vaccine. It's not that expensive and it's just once a year. So we only advocate the inactivated vaccine, not the live influenza vaccine. So household context. So sometimes we cannot vaccinate the child, but we can protect the child by vaccinating the family. So this is called herd immunity. So the recommended vaccines for them to take would be influenza, COVID, MMR, varicella, and pertussis. So by protecting the family, we are also protecting the child, who probably can't get the vaccine because it's got a very high disease burden. Live vaccines in household members are generally safe. There. So future directions. So hopefully we can improve correlates of vaccine protection beyond antibody titers. That means cellular immunity. So we need to individualize timing based on B-cell reconstitution after rituximab. Hopefully we can get new adjuvanted and high-dose vaccines for our patients. So current standard dose, let's say for instance, 0.5 ml for influenza vaccine. Sometimes hopefully we get more data on higher dose because their immune system is already blunted. If you give a higher dose, hopefully you can get better immunogenicity. Personalized vaccination schedule, so that's what I do sometimes for the children who are going for my therapy. I will get their vaccination schedule and try to help them, give them vaccines according to when's the best time, when is the main area, so that they have an idea where to wait for the vaccine to get it. And more on research into vaccination strategies for emerging biologics and small molecule inhibitors. So the key take-home message is infection is a major cause of morbidity and mortality in any of my pediatric rheumatic diseases. Inactivated vaccines remain safe and should not be delayed. Live vaccines need careful assessment based on disease activity and immunosuppressive therapy. So for vaccinate before you initiate rituximab, cyclophosphamide, or other intensive immunosuppressive treatments whenever feasible. And vaccination should be incorporated into routine rheumatology care with collaboration with other rheumatologists, infectious disease specialists, and primary care providers. So these are my key references. Thank you.
Thank you. you, Dr. Cham, for a very interesting lecture. The next topic, there is a slight change compared to your original program. The title is this vaccine allergy myth, misconception, and true contraindication. Let me introduce Dr. Muhammad Asri, clinical lecturer and pediatrician in the Department of Pediatrics, Faculty of Medicine and Health Sciences, University Putra, Malaysia. Dr. Asri graduated from University Malaya in year 2004 and obtained his master's in pediatrics from UKM in 2012. Since then, he has been active practice in clinical immunology and allergy. Let us welcome Dr. Asri.
Thank you, Chairman, for that gracious intro. I think it's too long. Next time we just do it short. Dr. Azri, here to talk, all right? So, hello again. Hi, I hope everyone's still GCS more than 3. Okay, so this is the topic of my talk. I would say, not my apologies, Dr. Anis couldn't make it. So I am the, what you call it, bidan terjun, right? So a short time to prepare this. So my other hat that I'm wearing, apart from immunology, we do get a lot of allergy referrals, right? So this should be very much a revision of what everyone already knows, okay? So you all remember 2020, 2021, what happened? COVID. Everyone suddenly became super specialists in vaccinology, right? Remember, unless you all want to suppress that memory lah, back in semua orang duduk kat rumah, always in fear, stress, to buat exercise kat rumah, right? Control your kids. Unfortunately, all the screen time not good, okay? So, remember, it's just a revision since super specialists are all in front of me. So later on, if you do have questions, hopefully not. Okay. My own opinion, and also based on the references I'll show you at the end, unless it's stated otherwise. Okay, so again, why is it so important that we do put an allergy or do not put an allergy label for someone who has a vaccine allergy, right? So if it's inaccurate, what happens, right? So you see an inaccurate allergy label, right? So it's not actually a proper allergy reaction. Then the next time the patient comes or the parent brings the child, they will refuse vaccination. So what happens when there's enough numbers of inadequate people getting vaccinations? You lose the herd immunity, right? So then you've got the immunity gap, okay? So then it becomes very important. So apart from just vaccine hesitancy, we really need to deal with proper, whether it is or it is not a vaccine allergy, right? So it's important that we know how to diagnose or detect these cases in the first place, right? So this is quite a common case that I tend to get a referral for, right? So terus dapat soalan kan. Now I ask you, okay? So 9-month-old after MMR. So the child gets an urticarial rash about 2 hours post vaccination. No angioedema, no wheezing, no hypotension. And they gave oral histamines and the child was fine within 30 minutes to an hour later, the urticaria resolved. So what would you do, right? Would you advise to avoid all future soalan dah ada jawapan, right? So we'll get back to this, right? So right? So at the end of the talk, what should you be able to do? Again, classify whether the suspected vaccine reaction, recognize and treat anaphylaxis. This is very important. If it does happen and it happens in front of you, know what is happening and know what to do, right? So identify contraindications and precautions, assess relevant vaccine components. So we'll talk about the components after this. Testing may or may not required, whether we should use selectively. Choose whether it's a full dose supervised or graded administration, and then refer the right patients to the right pathway, right? So vaccine-associated anaphylaxis is happen within 5 minutes. So you have to make sure that you get the diagnosis right, that the child is having, can be skin manifestation associated with respiratory tract involvement, right? If it's upper respiratory, they're sneezing, they're throat clearing because a lot of excessive nasal discharge, that's not laryngeal edema, that doesn't involve the bronchospasm, there's no hypotension, there's no cardiac involvement, there's no GI involvement or neurological involvement, right? So that will be like grade 1 or grade 2, which is mild and moderate reactions. The severe reactions is once they start involving laryngeal edema, bronchospasm, hypotension, it becomes very dangerous, right? So once you know that this is happening, the infant is having anaphylaxis, know what to do, give immediate IM adrenaline, and basically in the clinic setting, that's why it's done in the clinic setting, that you have all this ready, right? So again, I'll tell you about anaphylaxis after this. So adverse events following immunization, it is not just allergy, all right? So again, it can be, yes, vaccine product related. It can be immunization area. Dr. Sangeeta has pointed out one very important that coincidentally. Immunization stress related, we'll talk about this. So immunization stress related response, the infant or the child has an anxiety or stress related response as they know they're getting jabbed, right? So you have to differentiate it between that and allergy, whether it's quality or defect related, because there might be issues with the cold chain and then it affects the vaccine reactogenicity, right? So you have to be wary about that happening, right? So is it an immediate allergy or is it a mimic? Immediate allergy, yes, you have got the skin, urticaria, flushing, bronchospasm for the breathing, they have stridor, very dangerous. They can go tachycardic, right? The blood pressure might fall. Instead of, if it's a vasovagal, they look at you with the needle and then become pale, you know? Just like what the medical students, when they have to present, they become pale also. Okay, so they hyperventilate instead of wheeze or stridor. The BP might just fall, but then when you lie them down, they start recovering. Okay, so know how to differentiate, right? So then you know it's not contraindicated, right? So for the vasovagal syncope as well as immunization stress-related response, again, these are the two. So you got a pallor, you're sweating, you're nausea, they may vomit, right? As they see you, they start vomiting. You are already a known contraindication, they see you, okay? So not the vaccine, right? So they can become a bit bradycardic, a bit of loss of consciousness, so you have to detect whether it's a vasovagal. But it's quite scary if you see this happening in front of you, okay? So again, document everything and then we'll see whether it is a true allergy or it's just a vasovagal as well as immunization stress-related response, right? So common reactions that are not allergy, local reaction, you can get local reaction just from the vaccination. Sometimes you can get as bad as extensive limb swelling after a DTaP, right? So you get erythema and the swelling crosses joints, right? So it can get that bad. Sometimes you can get an arthritis reaction after vaccination. You give the vaccination, then there's an antigen antibody complex deposition. Then you get erythema. Sometimes it can ulcerate, right? That's also not an allergy, okay? They can also have systemic non-allergic because sometimes it's as a reaction, not allergic reaction. They can get fever as well as irritability. And sometimes post-MMR, you do get patients who do develop maculopapular rash, right? And in certain cases, it actually leads to an underlying diagnosis, as what one case Dr. Sanangita was talking about, skin. One of our patients actually had a proper measles after reaction phenotype, know how to diagnose. You see the skin, they got generalized urticaria, hypotension, and wheeze or stridor or multi-system. So this is the WHO guidelines for diagnosing systemic or severe anaphylaxis. All right. If you just have isolated urticaria, that's not anaphylaxis. Okay. So once you have all this and you fulfill anaphylaxis, don't wait. We don't send any laboratory investigations. You have to treat it. So remember, in an anaphylaxis, your mast cells are degranulating, producing the inflammatory mediators plus your histamine, right? So what the adrenaline does is basically it switches off. It stops the mast cell from degranulating, okay? So this is very important for everyone to know. You see it happening, you see the patient start stabilizing after giving the IM adrenaline when it is properly indicated, right? So we do see a lot of adrenaline hesitancy in cases of anaphylaxis. When you go retrospective, you would question, how come this patient has urticaria, has wheezing, has stridor, and also tachycardia or hypotension? Why just NAP salbutamol? Why is it just IV hydrocortisone and Piriton, right? So I know it's easy when you go through the retrospectroscope, you retrospectively see, but then you question, actually, did the doctor not realize or aware regarding anaphylactic reactions, right? So again, so we call for emergency support, give oxygen if they are having trouble breathing, right? There's one more that I should put, number 6. We observe them up to 4 hours after their reaction. For a biphasic, it can happen again, right? The reaction may happen again. Okay, so look for a biphasic phenomenon, right? So what in a vaccine can cause allergies? It's not just the content itself, the stabilizers, the proteins that aid the yeast, surfactants such as polyethylene glycol, the polysorbate. Sometimes they do contain a bit of neomycin antibiotics, but I'll tell you what's the precautions for that. The packaging, we do have patients who are latex allergic. So, you know, when you open the vial and you poke, some of it still contains a bit of latex. So be careful. And the vaccine antigen itself, right? So again, we got a lot of referrals for this. So egg allergy is not a contraindication for MMR, right? So the MMR is grown in chick embryo fibroblast. So the egg protein is very much negligible as compared to influenza vaccine. Yes, that one is has a bit more, but again, not contraindicated. You don't have to split the dose. You give half and then give another half, so no need. Still use normal vaccine precaution. If they do have a response, most likely it's the gelatin in the vaccine, right? But I think recent initiatives, there's no more gelatin in MMR vaccines. They are actually quite gelatin-free, so safer options, right? Egg allergy and influenza vaccine, again, not a big contraindication. So you would monitor them if they have egg allergy of any severity, from mild to moderate to severe. You would want to vaccinate them as per usual, okay? So again, no split dose, no vaccine skin test. I'll tell you about the vaccine skin test and what's the issue with this. And also just put on precautions. As for every patient who is receiving vaccinations in a clinic, you always have your emergency trolley, which is always should be nearby and properly stocked, yeah? So gelatin, yes, it can be, but as I said, nowadays, the MOH has put up that that's not gelatin-free, or the gelatin is not porcine-based, but we do have gelatin-free options, all right? So MMR, varicella, zoster vaccines may contain some allergens, right? So you would ask whether the patient has had gelatin reactions before, okay? So PG, PEG, this was quite controversy back then when the COVID vaccine came out. So yes, it does pose some problems for patients who have PEG allergies specifically. So yes, in this kind of cases, we do some allergy testing with skin prick test, but again, it's not properly validated. Same thing with polysorbate, right? Neomycin, if patients have had use of neomycin before and they have contact dermatitis, it's not a contraindication for vaccination. Sensitization, sometimes we do have patient who has latex, proper latex allergy, who go into anaphylaxis. So every precaution is taken if the patient has to require any vaccinations from a latex vial, right? So these are not allergic contraindications, right? So usually parents will come up to you, my child has eczema, my child has asthma, allergic rhinitis, severe eczema, right? So a lot of them will come up to you and say, see, my child not having any vaccinations because my child has severe eczema. All my children do not get vaccinations because all of them have severe eczema. Then I will post back to them, so let me get this right. None of them receive any vaccinations and still got severe eczema. So I just stay silent and then let that sink in, right? It's gone. Okay, sorry, I'm back. Okay, so again, you would vaccinate as usual. Food allergies, again, not contraindication. Family history of allergy, second, third degree cousin had allergy to vaccine, no. So you would still want to vaccinate the child, right? So mild URTI is not an absolute contraindication, right? So true contraindication is still allergic contraindication. You've had a proper severe allergic reaction, anaphylactic, to either the vaccine or the vaccine component. And some, yes, important non-allergic examples, as Dr. Cham has mentioned before, you live vaccines in patients who are severely immunocompromised. Of course, you don't want them to get the full-blown disease, right? As what my patient also got. The one who had severe combined immunodeficiency, they gave MMR and then had measles, okay? Luckily didn't go into encephalitis, right? Live vaccines during pregnancy, yes. If you do have patients who have encephalopathy within pertussis containing vaccine, right? Right, so precaution doesn't mean never, all right? So we don't usually say never vaccinate, all right? So sometimes we just defer a bit, then determine what's the actual reaction is, and then you would supervise whether they would need the vaccination. So in these cases where there is some concern, we would say yes, vaccinate, then we'll monitor in clinic, 2 hours, see whether there's any reaction, and if they're fine, they go back, right? So that's what we do in the allergy clinic. So take a reaction history, not an allergy history, so you determine what's the exact onset of the reaction after vaccination, whether they've got concurrent exposures, they were taking foods, are they on medications at that time, which would also contribute to the vaccination, not the vaccine itself, right? And if it happens, then of course we would want to know, you need to document what's the vaccine batch, what's the lot number, right? So then they will be able to determine and inform the manufacturer, right? So when skin testing may help, we don't commonly do this actually. So the patient has a lot of reactions, we do some skin testing. We actually take the vaccine and do a skin prick test. But this also has some drawbacks. So there were studies that actually showed in patients who had reactions, they actually had egg allergy, and then they subsequently want to do influenza. Those who had influenza vaccine reactions, they did 150 had reactions. Of those 50, they proceeded with vaccinations anyway, and none had anaphylaxis or severe allergic reactions. So it might not really help with skin prick testing as well, right? So it has its own limitation. Once you label and you do not get a negative result, so it does impact the patient's future influenza vaccinations. So it's got limited negative as well as positive predictive value, right? So whether you give full dose, supervised or graded administration, usually if it's not an adverse events following immunization, full dose, right? So you once you evaluate it's low risk, then again you full dose with appropriate observation. And you're uncertain whether they have an immediate reaction before, again, you would refer and then we would do a supervised administration, right? So if it's a component allergy and it's confirmed, then we look for alternative vaccinations, right? So who should be referred? Those who have had anaphylaxis after a vaccine. This is actually to also identify whether they are at risk of developing anaphylaxis to other, apart from just vaccinations, right? So if they have suspected gelatin allergy, we can probably do also a prick-to-prick test using gelatin allergens in the clinic, right? Or they have recurrent unexplained systemic reactions. They might have other underlying disease, not just allergies, okay? So usually you can manage without allergy referral if it's vasovagal, calm them down, right? If it's immunization, stress-related response, also it has to be in a calm setting, right? Okay, so back to our case. We asked, sorry, it was 9 months, not 12 months, right? Now the patient is 12 months, about to get vaccinated again. So some answered C, some answered D, some answered B, right? I'm hoping no one answered A, actually. Avoid all future vaccines, right? Don't answer A, right? Sorry, don't answer A. Okay. Right. So the best initial answer is probably B. What's B? So you may refer. Actually, C and D are also right. So I'm just detecting whether anyone answered A, right? You don't avoid, you can still give, right? So B is correct. C and D are also actually still correct. So sebenarnya one wrong answer lah is A, one wrong answer. Okay. So one case that I would want to ask, if this patient 2-year-old, can you get your DTaP hexasin, right? So they have this whole arm swollen after 24 hours. It's red and tender. Of course, again, you're worried whether it's an infected hematoma. But the child does not have any urticaria, wheeze, or hypotension, right? So I answered my own question actually. I wanted to put this as extensive limb swelling, so ignore this. Okay, one last scenario. So egg anaphylaxis and influenza vaccine. This mic likes to cut out, or they're censoring me. So 8-year-old with previous egg anaphylaxis. So what would you do regarding influenza vaccination? So would you? Okay, so no more censorship. So avoid influenza vaccination. You refer before you vaccinate. Use an egg-free vaccine. Not sure they have that. Give any age-appropriate influenza vaccine routinely. D, right? D, A, B, C, D. Right, so your answer is D. Baguslah, semua depan ni semua. Belakang tak nak jawab. I'm not that old, I can hear at the back lah. Can lah, sikit. Okay, the answer is D. You should give any age vaccine routinely, but of course, if you're concerned, you would want them to just hang around the clinic, right, for about an hour. If you're really that concerned and you have space in the clinic. If it's in KK, it could nasib lah. No space also, okay? All right, so again, key takeaways, don't equate temporal association with just allergy. It's not, everything is not allergy, right? So it can be other things we consider. But again, don't miss anaphylaxis. If you have an actual anaphylaxis case in front of you, do not be afraid. Don't have that adrenaline hesitancy, right? We get a lot of adrenaline hesitancy. And then when we prescribe the EpiPen to parents, actually the parents have read through, right? And then they consulted their team, which includes ChatGPT, Claude, Gemini, Glass Health, everything they consult. Got 5 teams, 5 different AI they consult, which also then supports them. Kan dia ada delusion sikit, right? So they are relieved when they are prescribed the EpiPen to bring home in case there's another anaphylactic reaction, right? So don't. So the doctors know the clinical signs and know the indications, specific indications, right? Again, we don't block unrelated. Of course, I'm sure everyone here are in support, I think, of vaccinations. I think the last one I don't need to mention, right? So these are my key guidance, the guidelines as well as key literature. Thank you very much.
Okay, actually, Dr. Azri to remain on stage because we will now have our panel discussion. Also, we would like to kindly invite our previous speakers, Dr. Cham and Dr. Sangeeta, to join us on stage for our panel discussion.
I think all of you agree the 3 speakers have given us very interesting lectures, clearing a lot of doubts and myths regarding vaccination. I would like to open the floor, the Q&A to the floor. Anybody will take question from the floor first before we take question from online participants. Yes.
Hello. Hi. Thank you. I'm Ati from Damansara. Sorry I came late. I missed almost all the lectures. But but I do have a question. Without listening to the lecture, I already have questions, particularly directed to Dr. Sangeeta. As you all know, BCG vaccine, as per WHO position paper back in 2018, already mentioned that whether you have scars or not, there is no need to repeat the vaccines. But we also realize that in our local context, that is a different guidelines. If you check with Klinik Kesihatan, even I think our own pediatrician has came out with the TB, BCG, management of TB guidelines, mentioned that if there is no scars, vaccine need to be repeated. And I also came to understand in KK, Klinik Kesihatan, 7 years old and below, whether they have scars or they have no scars, they are different pathway. So I find it very confusing because parents were asking, oh, WHO guidelines says this, but why our local guidelines say differently? Can I have your opinion on that? Thanks.
Yeah, I didn't speak on that because firstly, it's very controversial and there's so many guidelines. But it's a very good question because I spoke a lot on the complications earlier, but I do get this as personal calls from a lot of pediatricians as well. Like what Azri said as his disclaimer, this is my own disclaimer and my personal practice. So basically, I think under 5 is a priority, especially you're living in Malaysia. Above 5 is a plus and minus, Some parents, they want. Some parents, again, it's a discussion. I think that they must also understand that the person who is injecting the vaccine, as long as there's no complications, so don't inject intramuscularly because we do see some of these complications and it's actually quite devastating because there's a non-healing wound and all, and we've had that a few times. So I think it goes down to the risk, the area, where are you located? Are you going to travel? So all these things. But I think below 5, 100%. Above 5, like I said, it's very difficult because there's so many guidelines. Different people have different thoughts. So it's, I think you have to have a conversation. So if they do want it, some parents, they really want. So, I mean, you can't stop them also, there's no harm. Yeah, but I do explain that the risk of developing TB, BCG still protects only against severe TB and TB meningitis, but it doesn't protect against pulmonary TB and also, infection and all. So the risk is still there. So sometimes when I explain all this, they actually decide not to. Yeah, so it's a discussion. There's no right or wrong answer.
I think I got quite a number of questions from online. Ask if after 6 months BCG vaccination, there's no scar, when should we repeat?
So actually you can repeat. So if there's no scar and you're very sure that the BCG was given, you can actually proceed to repeat. So like I said, especially if it's below 5, I think they are at the highest risk because we know that most of our extrapulmonary TB and severe TB is actually below 5. So yeah, you can proceed to repeat. Oh, sorry, but the other thing also to make sure that they don't have any PID. So just make sure that they are otherwise well and all, because that's also another reason whether they could be immunocompromised. But if you are very sure that they are normal hosts, then there's no problem to repeat.
I interject a bit? Being immunologists, we are very afraid of double dosing someone who has an underlying immunodeficiency, right? So I do echo Dr. Arti's concern, right? Because it's not saying that we're in violation of the WHO guides. Scary because when you read through, you do notice that they say, yes, there's absence of scar doesn't mean there's no immunogenicity, right? So, jahat lah, but I will leave it at that. So, because parents will tell you no scars, so no scar. What would you then recommend, right? So we're
My practice over the last 20, 30 years, when I come across the same issue, unless I have suspicion that the child could be immunocompromised, usually I would recommend them to retake the BCG vaccine after 6 months.
Thank you for all the inputs. Yeah, I echo your concern. It's just that my point is WHO guidelines, WHO position papers are published upon clinical data and evidence base. So if you want to question why there is no scar and need not to be repeat the vaccine, there are data show, evidence show. But I'm not sure our local data, whether there are such evidence saying that, without scars, immunity is low, risk of infection is high, hence need to be repeat the vaccine. Let's say if we are in the private practice right nowadays, if you repeat the vaccines and patient went into complications, parents decided to bring this to court, medical legal. They say, WHO say no. Why do you? This is an international guide, and it says no. Why do you revaccine my child and causes complications? Then I think we will be in the very difficult situations to have ourselves covered. This is what I thought. That's why I thought, and in a country shouldn't have a different kind of practice. It has to be standardized, and WHO is supposed to be the benchmark and international guide that everybody should follow. Hence, it's called WHO. So I find it very odd why Malaysia have our own guidelines in vaccination basis. I hope you understand what my concern about.
No, I think it's a very valid concern, and actually it's not just to BCG, it's also to TB treatment. So personally, actually, I do see the CPG, but I actually follow the WHO module for treatment. So like I said, different people who manages differently, they will have their own input. Sadly, that's the same thing. So I think the best way is to have a discussion, document. I always tell the pediatricians that as well, because if you had a discussion, you've documented and you explain the risk versus benefits. So then, but like what I mentioned, I actually showed a few complications as well from BCG. So if you are not confident to give, please even ask your nurses to give. I think the technique also matters a lot. And I think that's the only way to protect yourself as well. Yeah, but because we do have, you can still show our guidelines as well, even though WHO is there, but it's all still guidelines. So it's mentioned, but it's up to the clinician. That's what I feel.
Another one question online is 3-month-old contact with smear positive TB. How long after BCG vaccine at birth can we do a month 2?
Okay, so this is also a difficult question because actually the moment you receive you receive your BCG, ideally you shouldn't be doing your MAN2 because you can still detect. That's why sometimes you do a IGRA, because IGRA is better, but it cannot be used below 2 years old. So, like I said, you have to assess the risk of TB in a child. I wouldn't rely on a MEN2. I will see the clinical status of the child. I'll see the risk factor, symptomatic. I will I think that's very important. If you refer early, actually, there are ways that we investigate and manage as well.
There's a question, I think, for Dr. Cham.
Okay, I have to be more specific. So if it's a high dose prednisolone, 2 per kilo or more than 20 milligrams for more than 14 days, so if you're on low dose prednisolone like 5 mg, 10 mg, you can vaccinate anytime. So if you're low dose, no issues. Biologics, you have to see what biologics you're talking about. There is the synthetic biologics, the JAK inhibitors, and also you got the biologics like the anti-TNF, the rituximab and all. So it depends. If your TNF inhibitor, in theory, inactivated vaccines that I mentioned earlier, safe. Live vaccines, better withhold. For rituximab, the window period must be after recovery. If you're given rituximab, that means like 6 months to 12 months, 6 months to 12 months after you've given the rituximab or before you've given the rituximab. Ideally, if let's say live vaccines, 1 month before the rituximab. If inactivated vaccines, 2 weeks before the rituximab. So it really depends. For JAK inhibitors, then it must be delayed for all live vaccines, but for inactivated vaccines, no problem, anytime. So I hope that answers that question.
All right. I think this question is for Dr. Sangeeta. What is your opinion in choosing between isoniazid 6 months and rifampicin 6 months treatment for latent TB?
Okay, so I think I mentioned this in the talk earlier. My personal choice is still isoniazid for 6 months only because I don't trust the parents. I don't trust the child, the compliance issues, and I don't want to waste 2 good drugs. So actually, I think it's rifampicin for 4 months, and the isoniazid rifampicin they give for 3 months. So if they are able to do dots, and I know that somebody is monitoring, I think you can have a shorter course. I know a lot of clinic kesihatan does that, but in private practice, sometimes I do choose 1 drug.
Okay, the next question, I think, can be either for Dr. Sangeeta or Dr. Asri. May I know which influenza vaccination do we follow, northern or southern strain, since both vaccines will be introduced at different time of the year?
So again, also a difficult question because we have influenza all year round, and if and you want to use that specific strain. Otherwise, whatever is available, you can take.
Yeah, I think that is, I think most of us adopt that same idea that we give whatever that is available, especially during an outbreak. You can't be choosing which strain you want to use because Geographically, Malaysia is in the northern hemisphere, but a lot of times we are using the southern hemisphere strain. Yeah. All right, let me see next. A case of mistaken given 2 BCG vaccine for a newborn on the same arm. Does it predispose the child for higher risk of developing BCG limb adenitis? That means the child has been given BCG twice. I think this has happened, I've come across a number of times that BCG vaccine has been given twice on the same site.
I hope it doesn't happen often, but like you mentioned, there's also BCG-related complications. So that is something we didn't really mention, but there are times that you get the complication from the BCG vaccine itself. So given twice, the risk of BCG-related complications might still be there. Again, you just have to monitor. You probably have to have a discussion with the family and just monitor the child. I think there's nothing much we can do. It's already given.
Yeah, personally, I've had this case when I was a master's student in an unknown national university. All right. So it's basically what happened. So actually, the parents were furious that they detected given double BCG, and the patient basically came in for, I think, some viral infection, viral pneumonia. They didn't actually bothered about the viral pneumonia. The child is in respiratory distress. They were really furious about the double BCG. So that's their focus. And I didn't notice that until, oh, your child is in distress. We have to give oxygen. We have to give this specific treatment. They didn't want to hear about that. It would just focus solely on the double BCG. And then actually what they wanted was admission by the hospital, that there was a mistake.
Yeah.
So the MO, that Clark, got it like crazy
Yeah,
got it
I
like
think
that night.
whatever honest mistake some of our healthcare professionals make, once the parents get angry, it is very, very difficult to pacify them.
So you have to be just good soft skill, and then document everything.
Okay, let's take another question. Can we start latent TB can we start treatment for latent TB with concurrently working out for active TB? And why is IGRA not suitable for less than 2-year-old?
Okay, so no, you shouldn't. I mean, if you think the patient has active TB disease, then you should not start latent TB. It's okay to wait, even if it's 2 weeks or what, because TB is a slow growing disease. It's not going to happen in 1 or 2 weeks. It's good. Sometimes it even takes years. So please work up the child first. If it's a place you need to biopsy first. If you need to do an X-ray, gastric lavage, do all that first. What was the second question? This is a nice question because it's an immunological question. So in order for you to have IGRA, a response, it basically measures your T cell function or T cell response. So actually it's a surrogate marker for T cell proliferation. So if you are below 2 years old, you do not have adequate T cell responses. In fact, I will be even more careful in those children less than 5. If you see the previous CPG guidelines, it was actually below 5. You are not supposed to use IGRA. Only very recently, they've changed it to less than 2. So that's why you cannot rely on IGRA for your below 2 years old because of the immune response. You need a good immune response to have your IGRA test positive.
Okay.
I nak sebut sikit.
Can
For the IGRA test, if you do get a result that's indeterminate, that means actually there's a failure on your part. When we take the test, we're supposed to mix it properly, and then the results come back as indeterminate. It's not because the patient might have a positive response. It's actually the doctor's fault for not mixing properly the mitogen. So be careful when you get the result, and then oh, we have to start anti-TB or latent TB because the IGRA is indeterminate. Indeterminate means somewhere in between, there's positive TB but not there. So be careful when you interpret the results.
Okay, due to time constraint, I think I will just end the session with the last question. Regarding this EpiPen, Dr. Asri, now you are also a visiting consultant here. Are you aware that the EpiPen is very expensive? And what are you what the what we call government institute like university clinics, are they giving out free EpiPen? Or how do you deal with cases where you think this patient need EpiPen but can't afford?
The answer is it's still paid, right? Of course, Sunway has one of the most expensive, but I cannot say. Sorry, I mean more reasonable price, but I do admit it's very not value for money. Getting anaphylaxis right now, so it's expensive, difficult to get, and then when you do get it or bring it in, the shelf life is already like you only have a few months or just 1 year left, right? So it's quite expensive for a 1 year product. Okay, so if I do have patients that do have financial issues, right, I do refer them through the proper NGOs, right? If it's a Muslim, we have zakat. If they are government officers, we ask them to claim. We write letters to JPA, we ask them to get support. Any specific anaphylactic society, I don't think so.
No, I think, so I also see a lot of patients with allergy, and it's very difficult, you are right, to get the EpiPen. So what we can do, I always tell parents that we are very lucky and blessed to be in Malaysia. You throw a stone, there's a GP clinic, there's a hospital. So you write an anaphylaxis plan and tell them where to go. So they always have that ready. And at least they know the emergency measures, what to do during an anaphylaxis, and then they go straight to the hospital. So that's something that I offer to them.
I mean, I've heard of some doctors who prepared these homemade adrenaline syringes for the patients.
Okay,
you know, because there are times you just don't have time to rush to the nearest clinic or hospital. You just have to jab the patient, right? So those kind of situation.
So I've actually checked with the pharmacies, okay, because this involves preparation, and personally I think that is very dangerous because not all are healthcare professionals, and during an emergency, how do you know how much you're taking? That's another thing. The stability. And, you know, even normal medications, we make a lot of mistakes. I mean, we are not the most well-literate when it comes to medications, unless it's a doctor or a nurse, a healthcare professional, I think I'll feel safer. But if you check with the pharmacists and all, there's actually no proper legal implications. So we have to be careful on that. So that will be my comment.
Okay, thank you very much, fellow speakers, and also thank you so much, Dr. Tan, for moderating such an engaging discussion, and also thank you for everyone for sharing their personal experiences, especially with the EpiPen story. We'd like to invite everyone down to kind of collect your token of appreciation before our tea break. Thank you very much. Okay, right. Now it's actually time for a short tea break. We are all invited to enjoy the refreshments outside prepared, and for you to take this opportunity to network and enjoy the booths and the exhibitions outside. Kindly return to the hall by 3:10 for our next symposium theme. As we continue, we look forward to welcoming you back shortly, and enjoy your tea break.